Hello. Hello.
Hello. Hello.
Yes, sir. Hello. Sir. Sir.
Hello. Hello.
ನಿಮ್ಮ ಹೆಸರು ಹೇಳಿ ಮೈಕಲ್ಲೇ.
Hello. Hello.
ಹ್ಮ್. ನಾನು ಹಾಲ್
Hello.
ಸಿ ಅಲ್ಲಿ ಇದ್ದೀನಿ ಈಗ. ಹಾಲ್ ಸಿ. ನೀವು ಹಾಲ್ ಸಿನಾ ಹಾಲ್ ಏನಾ?
Hello. Hello. Check.
ಮಾತಾಡೋಣ ಹಂಗೆ.
ಏನಂತ ಮಾತಾಡೋಣ? Hello. ಯೂಟ್ಯೂಬ್ ಅಲ್ಲಿ ಲೈವ್ ಆಯ್ತಾ? ಯೂಟ್ಯೂಬ್ ಅಲ್ಲಿ ಲೈವ್ ಆಯ್ತಾ? ಹಲೋ. ಅಲ್ಲೇ ಒಂದ್ ಸೆಟ್ ಇಕ್ಕಿದೀನಿ ನೋಡಲ್ಲಿ. ವೈರ್ ಸುತ್ತಿಕ್ಬಿಟ್ಟು ಒಂದು ಅಲ್ಲೇ ಎತ್ತಿಕ್ಕಿದೀನಿ. ಅಲ್ಲೇ ಇಕ್ಕಿದೀನಿ ನೋಡು.
Hello. 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 Can you hear me? So it's clear.
Hello, Junior. Hello, Junior.
Check.
Yeah, you guys are audible. Am I audible? Am I audible?
Junior, can you hear?
Am I audible?
Yes, check.
Can you hear me?
Yes.
Can you hear me?
Yes.
I can't hear you.
Can you hear?
No.
Go little far away, Junior.
No, not at all audible.
Go far away. Hello, check.
Not audible.
We can hear you.
Yeah, now you're audible. Now you're audible, and I can see you on screen as well.
Okay, good. Come back.
I'm also audible, right?
Yeah, come. You could hear, no? We could also hear you. It was fine. Okay. Check.
Hello. I have joined. Yeah.
ठीक है। हाँ हाँ, उनकी आ रही है, मेरी जा रही है उनको। अच्छा ठीक। Am I audible, Junior?
Oh, yes, you're audible to me. From
Yes, sir.
Varanasi.
Audible.
Nice.
Thank
Professor
you.
Ashok Kumar from BHU Varanasi.
Oh, thank you, sir. Thank you, sir.
Great. Good to see you all people.
Sir. Actually, the venue is very much nice, and since I was there for the workshop and then again, but today for an emergency meeting, I had to come back to the hospital, sir.
Okay. And how much is the attendance there in the conference? I understand there was some problem related to COVID kind of thing. I don't know what happened.
No, sir. There was some misunderstanding point of thing, but then the DHO came and they took the inspection, and they're quite happy with the arrangement and everything, sir. In fact, we have the area and all for, in fact, a lot more numbers. So they were quite happy with it, sir.
Okay. That's good.
Sir, can we do a mic check, please?
Yeah. Am I audible? I'm Dr. Ajit Mahapatra from Bhubaneswar.
Yes, sir.
Am I
You're
audible?
audible. Yes, yes, sir.
Okay. Thank you.
Sir, are you able to hear us?
Yes.
Yeah. There's no problem. Yes. The voice is clear. It's good.
Okay, just a few more minutes, sir. We're waiting for the moderator to arrive.
Okay. No issue.
Okay. Thank you, sir.
Hello, Dr. Arijit. Are you there? Arijit? Dr. Arijit? Dr. Arijit?
I think he was there a few minutes ago, but I'm sure he must be joining shortly.
Okay, okay.
Is there, probably is just muted and doing something.
Dr. Arijit, are you there? No. Yeah, Dr. Arijit.
Am I
Switch, your video. This is Dr. Saud. Dr. Arijit, switch on your video.
Am I audible?
Yeah.
शहरी कोई आएगी जरा
Hello.
शहरी
Good morning, sir.
Arijit,
Sir, namaskar.
नमस्कार. केमती अच्छा?
Sir, बढ़िया.
आमे मु केवल जगदीश आ मु दी जण अछु. ओके टी हॉल फांका पड़िची.
आज्ञा. ए हुए से या.
हो मु चलली रखुची.
Sir, नमस्कार.
बेस्ट ऑफ लक.
आज्ञा. Thank you, sir.
Dr. Sidhu Charke is not visible. Dr. Sidhu Charke.
हेलो हेलो ऑडियो क्यों नहीं आ रहा है हेलो डॉक्टर अशोक गुड मॉर्निंग
हाँ जी, गुड मॉर्निंग. हाउ आर यू?
चलो शुक्र है शुक्र है हाय अजीत गुड मॉर्निंग
Good to see you, Ashwini.
या सेम हियर
Okay.
So we are waiting for moderator.
Yes, I think. Dr. Arjit, are you from Bhubaneswar?
Yes, sir. Yes, sir. Good morning. I'm from Bhubaneswar.
Okay.
Good morning, Ashwini, sir.
Bhubaneswar में कैसा मौसम है? Is it
Yeah,
okay?
now it is bit colder. Unusually cold this year.
Okay. Banaras is quite cold. I mean, night temperature is 6 to 7 degrees Celsius.
Yeah, it doesn't go down so much, but still we are
Okay.
at 10-12 degrees.
10-12 is very comfortable.
हाँ जी. Ashwini sir, good morning.
Very good morning, Arijit. So we are having also unusual low temperature this time.
This
Now,
year
right
everyone,
now I'm in Chandigarh. Yeah, right now I'm in Chandigarh.
it must be very cold.
Climate change is a very serious issue, sir.
Right.
I think next time we should have a panel discussion of climate change and the new needs health.
Right,
It could be one of the topics, right?
Before that, we should have a study, a longitudinal study where we can
Yes,
see
yes.
what on
I think
units.
Ashwani, you can take up this challenge को panel discussion करवा दो इसके ऊपर.
आप टाइम दे दो, करवा देते हैं. Dr. Sohail, good morning. Where are you?
Good morning, sir. I am at Hubli now.
Okay.
Hubli. Oh, Hubli,
Hubli,
Bengal.
Karnataka.
Karnataka. Sorry. अच्छा अच्छा. वो तो Hubli.
Karnataka.
Okay. That's good.
I think we are waiting for Swarna Rekha madam.
Yeah.
Check. Check.
Good morning. A hearty welcome to everybody present here and to those joining us online. Welcome to day 3 of NEOCON 2021 Bengaluru. Without further ado, we will now commence the first panel discussion. But before that, I would like to tell you a story. In ancient Egypt, there was a place called Dakhle, which was an oasis. Recently, a few years back, an archaeological excavation was conducted at Dakhle and they found multiple skeletons. Interestingly, when they did a study of the bones, they found traces of tetracycline in those bones. Experts are postulating that this tetracycle was consumed in some form for the sake of protection. And what more, there was absolutely no trace of bone infection found in any of the multiple skeletons that were excavated. Now, I can't say how judiciously the ancient Egyptians used antibiotics, but most certainly they did not have to observe an antimicrobial awareness week. With antibiotic resistance rearing its ugly head all around the world, time has never been more crucial than now to speak more about controlling its use. That brings us to the first topic that will be discussed today, which is antibiotic stewardship in the NICU. Moderating this discussion will be Dr. Swarna Rekha Bhatt. She is a former HOD of the Department of Pediatrics and Neonatology at St. John's Medical College, Bengaluru. Ma'am has practiced as a consultant at Narayana Hridayalaya in the past and has won the Best Teacher Award by the NBE in 2014. Ma'am is the editor of a CARS textbook of pediatrics and has multiple publications both in the national and international level. Over to you, ma'am. Stage is yours.
Thank you. Good morning, everybody. Thank you. Thank you so much. Nice to see friends and kids. Okay, fine. See, the nice thing about this, I have been told that there is no session here till 1 o'clock. So with the permission of the organizers, we can continue for as long as it goes, I suppose. Let's start off this session with skip. Yeah. We'll start off with this session by introducing the panelists. Rajat, could you come over to the dais? Rajat is a senior consultant and HOD of neonatology at Sakra World Hospital, Bangalore, and a good friend of mine. And we have interacted a lot during the mentorship program that we had in Bangalore. Dr. Ashok Kumar, I think, is attending virtually. Dr. Ashok Kumar, welcome to the panel.
Thank you, ma'am.
Dean Research and Professor of Neonatology and Pediatrics at Banaras Hindu University, Varanasi. Sir, Varanasi has been a lot in the news, and I hope you enjoyed, like how we all enjoyed the Modi program in Varanasi.
Yeah.
Welcome, and I wish we could have welcomed you to Bangalore. Dr. Bharat is here. Bharat, please come. He's the assistant professor at Subharti Medical College and consultant neonatologist at Lokpriya Hospital in Meerut. And Bharat, I'm so happy that you have come all the way from Meerut to Bangalore despite the Omicron and Corona. Stay safe. Dr. Sidhu Charki, I don't know whether he's logged in still or not, but I'm sure he will join into the panel. He's the assistant professor and neonatologist at Sri B.M. Patil Medical College, Vijaypura. And welcome to you, Sidhu. I wish you were here, but I understand the constraints. We now move on to Dr. Suhail Ambi. Okay, Dr. Ashwini Sood. Dr. Ashwini Sood is Dean Academics, Adesh Medical College and Hospital. Welcome, sir. And again, I wish you were here for the panel. We have Dr. next one, Suhail Ambi from Karnataka. He is a consultant neonatologist and pediatrician at Sucharayu Hospital, Hubli. Welcome, Suhail, and how are things at Hubli? And Dr. Arjit Mohapatra. I think we had to communicate with him last minute because of some communication problems. Welcome to us. I wish you were here rather than in Odisha. He was the director of neonatal services, Jagannath Hospital, Bhubaneswar, and very interestingly, head translation research at AIPH University, Odisha. Unfortunately, I don't know, maybe we can bring in a little bit of translation research to AMS also, but thank you for being here virtually. With that introduction, yeah. With my, okay, fine, I will do that, all right. So thank you to the panelists for being here virtually and physically. You know, I like this hybrid conference, and I think a lot of our residents would want to be hybrid, and they would love to log into the NICU rounds, sitting and eating their breakfast at home. Maybe such times will come, and the times will come where the residents will log in and be virtual, and the consultants will be physical and present in the NICU. But I do hope it reverses. Okay, so let's start off with, yes, what am I doing? Going back, sorry. Okay. So the whole session is on antimicrobial stewardship in the NICU. sometimes called as antibiotic stewardship, but I think antimicrobial would include the fungal and the parasitic infections, and therefore is a better term. And not just the antibiotics, though predominantly we tend to stick to antibiotics. Antimicrobial stewardship, I know everybody is aware, but to highlight, has been defined as the optimal selection of antimicrobials that result in the best outcome with minimal toxicity and minimal impact on development of resistance. It also helps in preventing overuse and misuse of antibiotics. And the goals are very simple: appropriate antibiotic, correct dose, correct duration, correct route, etc. Prevent overuse and minimize development of resistance. So the crucial thing is about antimicrobial resistance. And for that, I'm going to ask Dr. Rajat to tell us about the problem of antimicrobial resistance in our NICUs. I'll have your slides.
Yep. Thank you. Audible?
Little loudly.
Louder. Okay. Good morning. Thanks for having us here. And such an important topic. When this was sent to us, I was thinking, do we still need to talk about this? And I think we need to talk about this and keep talking about this more and more. WHO is seized with this problem, and they have actually declared it as top 10 global public health threats facing humanity. Okay, and then as Madam was saying, misuse, overuse of antimicrobials, and then the concept of WASH, that is clean drinking water and sanitation and infection control, is a huge problem in many parts. But this is also not just a human cost, but also a cost for the global economy. So and antibiotics from the times that penicillin was discovered have been hailed to be savior of modern medicine, one of the miracles of modern medicines. We could go and treat cancer patients, we could treat extremely vulnerable neonates in ICUs because we were able to fight infections off. But maybe this advancement in medicine is at increased risk. So just to put a number on something, if the current rate of antimicrobial resistance continues unhindered, by 2050, AMR related deaths will overtake any other cause of death globally. So by several folds. So now it is about 1 million or so. So it will be 10 million or so. So if you look at where we are, what kind of surveillance is happening, it's quite heartening to see that several hundred countries have come together in an alliance called Global Alliance Against Resistance on Antibiotic Use, surveillance GLAS system, and then they do publish periodically. So I've just picked up 3 main gram-negative bacteria that are relevant for our NICU, and the first one I've picked up is Acinetobacter. And if you see this whisker plot where the shade goes from dark gray to light gray, that is the median. So carbapenem resistance is about 60 to 70. So we'll not go into the details of IQR and other things, but a huge chunk of them are resistant. So this is global data from about 120 or 140 surveillance centers from where antibiotic sensitivity pattern is available. So the next slide will show us that the other common bug we encounter in early neonatal sepsis is E. coli, bloodstream infection. So even there, about 40 to 50 is the resistance to cephalosporins. The other common one is Klebsiella. So worldwide, the situation is not that dire, but I think speaking to colleagues who work in huge, heavy volume centers, MDR Klebsiella is a huge concern. So, so if we look at, we know we've all heard about Dennis study, so the Delhi Neonatal Infection Consortium study, so which was published a few years ago. So what they did was they looked at about 14,000, just under 14,000 neonates admitted with sepsis in about 4 centers, of which about 6 to 7% were culture positive sepsis, and we'll see what it showed. So about 2/3 of these babies had MDR. So the top one there is very worryingly Acinetobacter, Klebsiella E. coli. And if you see the last column there, that is the case fatality ratio. So these units would know that they would be getting MDR bugs. They would have probably hiked up the antibiotics at the very beginning, because that's probably the most easiest thing to do is prescribe antibiotics, whether rightly or wrongly. So the MDR rates are very high. Acinetobacter is about 82%, Klebsiella is 54%, E. coli 38%, Enterobacter 50%. And even if you looked at gram-positive isolates, MRSA and VRE are creeping up. So if this doesn't scare us, I don't know what will, because one day when we are unwell, debilitated, and we are admitted in a ward or an ICU, there'll be a simple bug that our physician or our intensivist will not be able to get rid of.
Yes, fine. I specifically gave a little more time for this particular topic because I think the idea that it was that Rajat should scare all of us, and thank you for scaring all of us. And if somebody is not scared listening to it, there's something wrong with them. All right. So I think we have set the stage as to why we need an antimicrobial stewardship program. And I'm going to ask Dr. Ashok Kumar as to what would be the, see, everybody knows that you need to set up an AMS committee and an AMS team, but what would be the challenges in setting up an AMS committee and a team? Dr. Ashok.
Okay. So very good morning to all. The greetings from Banaras Hindu University. So if you look at AMS program, it requires first and foremost is significant funding in terms of personnel, finances, your telemedicine, and the related things. You need a committed team of experts who are passionate about the cause of antimicrobial stewardship. They are dedicated and committed. You need a reliable microbiological laboratory. Only then you will be able to back up your efforts, support your efforts towards using the antibiotics judiciously. And then efficient hospital information system, so the information can be transmitted to all the stakeholders in a timely manner. The measure should be context specific. What I mean to say, the things which are applicable or successful in a developed world may not hold true in our setup. So we have to think innovatively in a different manner. And all these activities, antimicrobial stewardship, should be complementary to infection prevention and control initiatives. It should not be done in isolation or as a standalone activity. Only then, why we overuse or misuse antibiotics? Because we have very high rates of infection. So we have to control infection, we have to prevent infection, and then we have to use antibiotics judiciously. Only then we can reach towards antimicrobial stewardship. Can I have the next slide?
Yeah, sorry.
So what are the challenges in implementing antimicrobial stewardship program? This article appears in the Frontiers in Public Health. It's from Kerala. There are a number of things. I would start from the absence of champions. See, in any activity, in any QI project, or in any intervention, you need little champions who are committed to the cause, who can transmit their energy and dynamism towards using the antibiotics judiciously. So every team should have one or two champions who can spread the message, who can motivate the people, who can encourage the people. Then one of the challenges having a time constraint. The OPDs, especially in the government hospitals, are very busy. A lot of patients are there. So the usual, the problem that the people are so busy in dealing with the patients, there's hardly any time to think over the judicious use of antibiotics. But this is also an opportunity when the number of patients is very high. We tend to use antibiotics very frequently. And that is the one situation where we should be thinking more progressively regarding the judicious use of antibiotics. There's also lack of interdepartmental coordination between microlab, patholab, pediatrics, medicine, hospital information system. There are minimal supporting facilities. There is no dedicated or committed funding from the hospital side or from the institute side for undertaking these activities. There is also poor this enforcement of regulations, because the regulations are not followed up properly. So the people are not committed towards the judicious use of antibiotics. The another challenge is the utility of antibiogram is also questionable. In fact, in many places, people do not have much faith in micro lab. Even when the blood culture report is negative or blood culture report says single organism, we tend to use broad spectrum combination antibiotics because let's say the blood culture says Klebsiella pneumoniae is there. So we should narrow down to single antibiotic, but people will keep on using the coverage, which is also dealing with gram positive like vancomycin or other antibiotics, because they don't have much faith in micro lab. There is also some competition among the doctors, maybe in the private setup, where they have to prescribe antibiotics on their livelihood. But that is one of the factors which came out in this Kerala study. So these are the challenges in implementing antimicrobial stewardship. So what are the core elements of antimicrobial stewardship? You need a committed leadership. The team should be multidisciplinary. It should be the clinicians, infectious disease specialists, micro people, and other person. Is social assessment. You have to find out what is the load of this antibiotic resistance. Accordingly, you have to plan your policies. There should be interventions to improve the antibiotic use. There should be continuous surveillance. The report of this, the antimicrobial, the sensitivity pattern has to be shared with all the stakeholders, and we have to educate all the members, be it doctors, resident doctors, consultants, staff nurses, and other people regarding the judicious use of antibiotics. Can I have the other slide? Yes. So the multidisciplinary team, the composition is, there should be a program leader, preferably an infectious disease specialist or a clinician. Then you need persons from infection prevention and control team, informatics and system, the doctors, of course. This is not clear to me. Nurses, of course, and the quality management and the micro team. So, I mean, it is the multidisciplinary. It involves many people. The team should not be too big. Maybe 6 to 8 persons who are able to work as a team effectively and can then undertake this activity of antimicrobial stewardship. So that is my take on this, the question.
Thank you, Dr. Ashok Kumar. I think you brought out some very important points. And I think the first message that you gave, that antimicrobial stewardship should run hand in hand with the infection control prevention program of the unit or institution. It can't be separate from that. But I don't think the ICP should take on this. There should be 2 groups discussing this or doing it, but it should be, unless there is a good infection control prevention policy and action in the particular institution or unit, AMS is not going to go on. Just a kind of comment, which is partly true and partly in jest, that antimicrobial stewardship program and infection control programs are definitely beneficial to prevent antimicrobial resistance and to the patient and their families, but need not necessarily be beneficial to the management.
Yeah,
I've had this
that point is well taken. Yes.
Brought down the infection control, infections so much that use of multi-drug resistance came down, and the use of antibiotics came down, and the use of investigations came down, and therefore the economy suffered, quote unquote. But still, I would request all of us to keep that away from our mind and focus on the baby and focus on what Rajat said, that soon we will not have any antibiotic to cure ourselves. You can be a little selfish, and if not for anything else, I think we need to concentrate on this AMS program. I think the next slide was for Sidhu, Dr. Sidhu Charaki. I believe he is not yet logged in. And we will go on to the next topic to, I think, the youngest participant here. I don't know, but he looks the youngest. Dr. Bharat, can you tell us about the AWARE group of antibiotics? Not yet. Not yet. You still look young. Can we have another mic, please? I think you can start off, Bharat. I'm sure you can speak loudly. Yeah.
Madam is not
audible.
audible on the
Not
virtual
audible to
part.
us.
Mic, he's getting the mic, he's getting.
I think he can come to the dais and then speak from there.
Of antibiotic, WHO has classified antibiotic into 3 categories. First is excess, second is watch, and third is reserve group. So basically, AWARE is an acronym just to make sure that right antibiotic is used at the right time. So this has been the classification given by WHO. Next slide. As we all know that antibiotic resistance is now a global threat. And just to handle antibiotic more responsibly and safely, WHO has come up with this classification. So first group is the excess group. So this is a first line antibiotic for most common and serious bacterial infection which has to be used. This list has been compiled from the list of WHO essential medicine, and excess medicine should be available at all the centers all the time. Second category, which is the watch category. Among watch category also, there are few antibiotics which are part of WHO essential list of medicine. In watch list also, there are few antibiotics which are to be used as the first line. It's not that only excess antibiotic are to be used as first line. Even for some category, like for meningitis, watch category of antibiotic has to be the first line. But this has to be kept in the watch category because watch and reserve category, they are at higher risk of resistance. They are precious antibiotic. If we keep on using them for longer time, we'll not be able to use them in the future generations. And last is the reserve category, which we have to use very sparingly. Only for multi-drug resistant bugs, we have to use the reserve category. And what is this basis of classification? This classification basis based on their impact on antibiotic resistance and basically for surveillance purpose. It is not based on their effect on the clinical effect. Like it's not like that SS antibiotic is weaker or watch antibiotic is stronger. It's all classified so that various countries can do the surveillance program and etc. Next slide. Just to give an example, like how this works. Like if you see pharyngitis or ear infection, what is the first line? First line is actually no antibiotic because majority of them are viral. So they are self-limited disease. So you don't need antibiotic all the time. So even if it's bacterial and you want to use, like first excess antibiotic for otitis media will be amoxicillin. And if it doesn't work, then second choice is amoxiclav. That is also belong to excess group. Similarly, for pharyngitis, first line is no antibiotic therapy because majority are viral, self-limited. If you want to use for a bacterial infection, then first line is again amoxicillin, which is belong to excess group. And if it doesn't work, then second choice is clarithromycin. This clarithromycin, however, belongs to the watch group of antibiotics. For pyelonephritis, majority of them are bacterial. If you don't treat, kidney is going to get damaged and it's going to run into acute kidney injury or even chronic kidney disease. So you have to treat with antibiotic. You cannot escape from antibiotic once you diagnose pyelonephritis. So the first category in this is ciprofloxacin. I already told you it's not that the always excess group are the first line. For some infections like meningitis, pyelonephritis, you have to go ahead and give the watch group of antibiotic, which is there, ciprofloxacin. And second category, and second line is again from the watch category, like cefotaxime. Next slide. Just to highlight or make everyone aware, this is a free portal available on AWARE WHO website. If you put on the net this link, a whole model will come. Like on the left side, there are various filters, like which antibiotic you want, which category of drug you want to use, and what is the indication. Like as I have mentioned, like indication is sepsis without septic shock. So then again, it asks for the age group. Like I have put here children 1 month to less than 1 year. So if we want to treat sepsis without septic shock, this is the model list of essential medicine given by WHO. If you further open these categories, it will further tell you whether it belongs to excess group, watch group, or reserve group, so that you're always aware what are you using. If I just tell you, in newborns, which we commonly use antibiotic, ampicillin, gentamicin, amikacin, this all belong to the excess group. While your piperacillin, tazobactam, meropenem, ciproflox, cefotaxime, they all belong to watch group. And your colistin, polymyxin, aztreonam, tigecycline all belong to the reserve category. Next slide. WHO wants that all countries should use at least 60% of their antibiotic spectrum usage should come from the excess group. And this 60% target we need to achieve by 2023. just to make everyone aware, India is not the part of this global work which is going on. India doesn't monitor at all which antibiotic I use. Everyone is just using antibiotic. We're not at all monitoring whether we are using excess antibiotic or watch group. We just don't know. Even country like Bangladesh, they are doing, but we are not part of the list, just to make everyone aware.
Thank you, Bharat, for those very useful points on what is this AWARE group. And I think it's got a very nice acronym of we need to be aware. And the last point about India not being in this group, I hope, I'm sure, I'm very positive we will soon get into this group to make sure such things happen. Thank you, Bharat. Very nice. Thank you. Yeah, I think this just people need to know this, they can read it and they can understand.
Yeah, it's the need of the hour. Yeah. Antibiotics are not like other medicine. They are vulnerable. They are useful, but they are vulnerable. They are themselves vulnerable. At one time, they are not going to work. So we all need to adopt AWARE to make sure antibiotics keep working for all of us and help to make the world safer and healthier. Thank you.
And thank you so much, and particularly for explaining the basis of classification of the AWARE group, because that makes it more sensible for us to understand what it is. It's got nothing to do with the pharmaceutical company or the price or the clinical outcome. Thank you so much. Okay, Dr. Bharat did mention about the reserved or restricted group of antibiotics. In fact, I would like to call it as a conserved group or conservable group of antibiotics. And I would like to ask Dr. Ashwini Sood to highlight a little points about this. Dr. Ashwini?
Yeah, good morning to everyone. Am I audible?
Yes, sir.
Yeah, good morning. And thanks for organizer. Actually, just to continue with what Dr. Bharat said, that we had this what we call a restricted, reserved or conserved one. But if you look into the data, probably most of the hospitals, as we are talking about economics in antibiotic use, probably these are the antibiotics which are misused most of the time, which we should be keeping as a reserved one. And if you want to define as per WHO definition, so these are antibiotics and classes of antibiotic which ideally should be reserved for treatment of either confirmed or suspected infection which are by multi-drug resistant organism, what we call as MDRO. But we don't wait for MDRO, as Dr. Ashok was telling in the AMS presentation. Actually, it is the idea to start with at least 2 antibiotics to begin with. Ideally, it should be the last resort, but what is happening because of the fear in our colleague, this become the first resort most of the time. And if you go further into the WHO priority pathogen list, then it is mentioned there that these are the selected reserve group like meropenem, as Dr. Bharat was highlighting rightly. But if you look into the use, which probably we are not monitoring in our country, the carbapenems and cephalosporin are the most commonly abused antibiotic right now. Whether they are indicated or not indicated, that's another issue. But that becomes the first prescription, even if you look into the ICUs, especially NICU and PICU. Important thing is that they should be available, and this is a long list starting from WHO, and we start from the Astronome, then Curomnom, Cefiderocol, most of them are not available. So right now the concern is the misuse of tigecycline as well as the polymyxin. So these are actually most of the time these are being used. Another thing which I would like to say is that most of the time we have some irrational combination which are licensed by the DCGI, and when we are dealing in a patient, especially in NICU, and when we don't think there's another hope left, so we probably try to overuse or misuse them. So that's another reason for increasing in the multi-drug resistant organism and AMS. So this is a long list. One need to be care, and as Dr. Bharat has given us an idea, we should be just having a list and access that and which antibiotic probably, but probably we don't find that time and it's going to the first prescription. So this is the long list of reserve group for antibiotic. With this, we move on to the next part. Thank you, madam.
Thank you, Dr. Ashwini, for highlighting the importance of the reserved group and why is it called reserved group. And I do agree with you that this is possibly the most commonly used antibiotics in a lot of tertiary intensive care units. And I hope things change. And I'm going to reiterate this fact a little later also. Unless we have our infection control prevention practices in place, we will continue to need to use these antibiotics. So we have to be almost dictatorial about our infection control prevention practices, and then only we'll be able to follow the policies of antimicrobial stewardship. This is a difficult question, and the next one is a little more difficult, but Dr. Suhail, what are the challenges of developing an antibiotic policy? Because one of the crucial things about an AMS program is to develop an antibiotic policy, which is obviously going to be useful for that particular unit or hospital. It can't be a kind of general one. Go ahead, Dr.
Thank you, madam. Very good morning to all. It's a privilege to be involved with this panel. Madam, the challenge is what we see is first thing, the very first step which comes is the fear and with the look of a severe sick looking baby. The moment anybody sees a sick looking neonate, they're compelled to start an antibiotic. They don't want to miss an infection. But we need to understand that all sick looking babies are not always because of infection. Because the signs and symptoms in neonates are so non-specific, especially we have non-infectious conditions like we see apnea of prematurity, we have GER, then we have seizures, which also can be because of non-infectious causes. Then we have the peer pressure, the other consultants, which, the moment the second opinion is so easily available, and one person telling to the patients that, no antibiotic has been used. So this is the pressure that, the consultants now are feeling. And then we see that especially after vaginal deliveries, the acute phase reactants, are elevated. This is another factor where we feel the urge to start an antibiotic. But as we know, we can still withhold antibiotic. And the next important thing, as sir had already told, that, the unreliability on the blood cultures. It could be, because we don't trust the way our labs are you're doing it. And then the problems with the sample collection. Sometimes the blood collected, the quantity is not sufficient. The technique of this nursing staff is not there. And then the delay in the reporting, because sometimes, especially in this two-tier city, we have to send the samples to the metros and then it comes from there. Luckily, now this thing is being taken care of almost in every place. So once we start relying on our blood cultures, if it is negative, we need to take it like, the baby is not having an infection. And so that once we are convinced ourselves that the baby is not having infection, that is the time when we can, really think of stopping an antibiotic. Then because of this unreliability on the blood cultures, having a proper antibiogram, because many units in the two-tier cities, we see that they don't order blood culture at admission or whenever needed. So once you don't rely on blood cultures, you'll not be able to have the resistance pattern. Resistance pattern is the most important thing, where we can have an antibiogram and then plan accordingly, according to the.
Sohail, your audio is.
Yes, sir.
I'm not audible.
Little loudly.
Yeah.
Speak a little loudly.
Okay. So once we start relying on blood cultures, then we'll have a proper, we trust the blood cultures. We'll send blood culture for every, especially ICU admissions. Then we'll have a proper resistance pattern for our units. And then we can go ahead with an antibiogram. And the other resistances, as I had already told, we need a big team. Like we need a consultant, then we need the microbiologist to help us. We need the infection control nurses, the statisticians, and then the enforcement authority from the management as well. And as Madam said, it will have an impact on the economics later. So we need a champion who can take this up and then tell people that, see, this is not anything lesser than the climate change that we are talking about. 2 years back, if somebody spoke about climate change, nobody believed in it. But we are probably heading to a pre-penicillin era where, infection was like a death sentence to a patient. We don't want to land ourselves there. So that is the importance that we need to form this antibiotic stewardship team and then form this antibiotic policy. And even at the national level, we have the national antibiotic policies. So, people can go there and just make few changes what they want for their private units. And even nowadays, all districts are also coming up with their own resistance pattern. So once we can go to them and get the resistance pattern of our area, if you don't have it for our unit, that will help. And the most important concern still, I feel that the variability in the prescription of consultants, the fear of losing the neonate, and the third one is camaraderie between consultants.
Thank you so much, Dr. Suhail, for highlighting the specific problems to neonates in recognizing, in diagnosing, in proving culture positive, and therefore in developing an antibiotic policy. But unless we have an antibiotic policy, you can't tell people this is what you need to use. So within the limitations, it's still important for us to form an antibiotic policy. And that, I think, is the most difficult question that I'm going to ask, which is not, sorry, I think it's not in the slide here, is to Dr. Arjit Mohapatra. In the absence of an antibiogram, antibiogram is what Dr. Rajat had showed earlier, what is the organisms and what is the sensitivity resistance pattern. So in the absence of an antibiogram, how do we go about having an antibiotic policy? Dr. Arjit.
Good morning. Good morning, everyone. In the first place, thanks to the organizers to give me the opportunity, and a great bit of thanks to Professor Swarnarekha, who is one of the first generation teachers of neonatology of our area. Though I have completed my DM almost 2 decades back, she was the teacher of our era. So thanks, madam, to include me at the last moment, knowing that, and she was gracious enough to give me a call yesterday evening. So I was so humbled. So if you do not have an antibiogram or the antibiotic sensitivity pattern of a particular institution or a city even, which is, as Dr. Suhail told, many of the second tier and third tier cities, the NICUs are now coming up. But with the lack of support of a good microbiology lab and a microbiologist and a team which could give you a presentation that this is the antibiotic sensitivity or the resistant pattern of your institution, of your NICU, it's very difficult to go ahead. But that is the reality that is in the current situation, where most of the NICs work with, apart from keeping apart the tertiary care, the teaching institutes, the most of other second level, third level, on the other way, cities and smaller places that you do not have an access to a good microbiology lab, forget aside the back techs and the high tech things. So in that kind of situation, we call it an empiric antibiotic therapy or policy. But having heard, starting from Dr. Rajat, who's really scared us about the extent of antibiotic resistance, that what are the situation we are heading to, like Dr. Suhail told, nobody believed in climate change 2 years back, like that. Nobody believed of us, probably many of us didn't believe in antibiotic resistance or the emergence of resistant strain of microorganisms, so-called the superbugs, which would be resistant. When you really get devastated, when you get a report in the NICU that an organism has grown and all R, means it's all resistant to everything, you get scared and the baby is so bad, what to do now? So that kind of situation we have already landed in, probably. We are like sitting on a ticking bomb when it will explode. So keeping on one side this kind of situation, and on the other side, you do not have anything to guide, but you have to treat the baby. So the best policy is to start with no antibiotics whenever possible. So by that, what I mean to say, that avoid the avoidables. Like many of us, or quite a bit of us, start antibiotics just for an indication of cesarean section. By virtue that a baby has been born in a cesarean section. I'm talking of smaller nursing homes, smaller hospitals, or where the pediatrician just visits once in 2 days, that any baby who is born by cesarean to a mother without any risk factors, without going with anything, they will get some intramuscular antibiotics twice a day for 3 days, 5 days, like that. So those kind of things are really unnecessary and unwarranted, should be avoided. And the second thing comes when a suspected sepsis, when the suspected sepsis comes to the NICU or gets admitted to the first level of care, the baby comes. So like Dr. Suel tells, that we have to first distinguish between non-infectious causes in which the baby could have been presented, the apnea, the GER, and the other things, the sepsis mimickers, so to say. And obviously we'll be sending the septic screen or the septic markers to get and interpret it not on that face value, knowing very well that CRP, a very commonly used investigation, is raised in 3 most common conditions in NICU, that is asphyxia, RDS, and meconium aspiration. These 3 conditions, you get a very high CRP value. So we get hyper that, oh, CRPs are 80s, 90s, 8 times increased from the standards. So give higher antibiotics. No, you have to understand that CRP is a non-specific marker of inflammation, and 3 most common conditions, as I told, asphyxia, RDS, and meconium, will have a higher CRP. So likewise, we have to interpret other investigations as well and decide about the real use of antibiotics. In the first place, start with the lowest possible, like something like ampicillin, gentamicin, like from the access group, so to say, from the IWAR list, from the access group. Then depending on the clinical situation, if you have and the other investigation reports, you can scale up or scale down. Suppose you are forced to use a broad spectrum higher antibiotic like meropenem or vancomycin with the suspicion that this baby is in real septic shock, this baby is suspected meningitis. So if you have started using it, take care to scale down as soon as you get your investigations report, you get a CSF report which says normal, stop vancomycin. You get your other investigation reports, your sepsis markers, your ProCal reports, and scale down the antibiotics and have the courage to stop the antibiotics also. So that is what is important. That is what, like, going by your instincts to use less rather than use more. So nowadays the thing is less is more. So we have to think in that line. And also the prevention is very important. The preventive antibiotics, any baby admitted to NICU gets antibiotic. And unfortunately, the first line of antibiotics has become piperacillin tazobactam in many places, which should not be ideally.
Thank you so much, Dr. Arjit.
Thank you.
Or you want to sum up? Go ahead, please.
Yeah, so that is the thing, that we have to use the least amount, not use the least amount, and whenever possible, scale down depending on the clinical situation and investigation reports. Thank you.
Thank you so much for highlighting that the process has to be there. The antibiogram will help us to decide what antibiotics. But unless a process is there as to when you will not use antibiotics, and I'm really thankful for highlighting that. And then you have a first line and a second line and a third line based on your experience or a regional experience. I think we can still form a policy, but for it to be very specific, we need an antibiogram. But unfortunately, the current antibiograms are so scary that we may encourage people to use the reserved antibiotics, and therefore we need to bring down infections. That is the bottom line. We'll move on to the next set of questions. I think we have about 15 minutes or 10 minutes time. Again, except for Rajat's question, which is a little theoretical, all the others are going to be practical situations, and I want a quick answer from the panelists. I don't know why I have favored Rajat. It just happened that his name was the first one. So I don't know whether I have favored him or unfavored him. I'm not very sure. Rajat, how do we audit or monitor antibiotics? I think it's very important to audit. Whatever we do, we need to audit. I mean, just previously I was talking in the ethics session. You can do a training, but if there is no assessment, there is no point training because nobody is going to take it seriously. So similarly, unless we audit what we are doing, we're not going to know whether we are going in the right direction or not, and therefore go ahead with the auditing process very quickly.
Yeah, thank you. So, unless we audit, see, the first thing I labeled it, my slide as, is there a problem? So a lot of us walk around saying this, all this antibiotic resistance, MDR and all is somebody else's problem, our unit is good, our rates are less. But unless you actually look into what you're doing and what you have, you will be that unit, if you're not already there, which will have difficulties. So there are different ways of looking at whether you really have a problem or not. So for example, you can look at percentage of NICU admissions that were ever on antibiotic, or percentage of NICU admissions with 2 or more courses of antibiotic. So percentage of them on second, third line antibiotic. And I've called red listed because, people still need to be aware of people at least understand red. So how many of your babies have been put on that? And how many empirically started antibiotics have you discontinued? That is very important. And do you have an antibiotic justification form signed by a consultant? If I have to continue beyond 48 hours, I need to sign why am I continuing? And then at a much higher level, actually, you can compare peer-to-peer or internationally by something called as DDD. So the defined daily dosage per 100 beds. This is an inpatient measure and it's a WHO measure. So you can compare, for example, if you're a medical college, you can compare with other medical colleges and see what is your antibiotic consumption as a hospital. Next slide, please. So then you need a little bit of tools and processes. You have the following tools. We have been talking about it, antibiotic policy, but more importantly, I'm looking at certain places where we have not revised it. At least we need to say we're not going to do anything different. Revise. You have an antibiotic justification form. You have somebody who is watching over you. It could be a clinical pharmacist. It could be an infection control nurse. It could be a microbiologist, but a specified person, more likely somebody who is clinical. So clinical pharmacist. HICC rounds, and most importantly, you need to have a unit champion. So I think intensivists or the senior nurses of the unit should be identified as unit champions. If somebody coming externally from HICC, it may not work very well. I think I'll sum up with what I've said in the end. Next slide. So types of audit. So I'm very fond of doing snap audit. So you just don't say you're auditing, just pull out all the prescriptions that you have or drug cards you have, and it will give you a flavor of what you're doing. But prospective audit actually helps you put things in place. So you can prospectively audit against a set standard, a standard that you yourself has set for yourself perhaps, and go through PDSA cycles and quality improvement. At a supra-organizational level, we need to look at antimicrobial consumption. So we know that we don't just use antibiotics in NICUs, not just in hospitals, not just in OPDs, but also in poultry industry and other things. So the countries have to sign up for AMS at organization level and at national level. So there is a GLAS network that I alluded to. So there's a lot of work needs to be done, but the starting point is to perhaps assume that you or your unit or you personally have a problem, and to have that null hypothesis and then disprove that you don't have a problem, or if you have a problem, address it.
Thank you, Dr. Rajat. We have said that audit is important and there is no end to what we can audit, and you can choose what you want to audit depending on your clinical situation. But auditing is important, giving the feedback is important, changing policies based on the auditing is important. Now, Dr. Ashok Kumar, we have done an audit in a particular NICU, and generally the impression is there is an excessive use of antibiotics. I'm not talking about which group, but there's an excessive use of antibiotics. As an administrator or as the champion of that unit, what steps would you take to rectify this?
Okay. So this is a very common problem that we tend to use antibiotics very liberally or freely. So let's understand the drivers of antibiotic uses. Overall, there are 3 situations the antibiotics are used. First is prophylaxis against infection. Nowadays, there's hardly any space or indication or region for using antibiotics prophylactically. But still, when we go to visits to SNCUs or even NICUs, babies with meconium aspiration syndrome, perinatal asphyxia, even a, let's say, extremely low birth weight baby, no problem, is on IV fluids for no rhyme or reason and getting antibiotics in order to so-called prevent infection. So there should be hardly any indication of prophylactic antibiotic. The second situation is empirical treatment of infection, which is a common problem where we tend to use or overuse or misuse antibiotics. I will be dwelling on it shortly. In the third year, targeted treatment of infection. You have isolated the organism, we have to treat the infection. So the studies suggest that antibiotics are both overused in both term and the preterm babies. And the most neonatal antibiotic prescription is for suspected rather than for proven infection. The clinical sepsis is, I think, 5 to 10 times the antibiotic use is common compared to culture positive sepsis. And it has been documented time and again that most antibiotic use is unwarranted. It's really not needed. So there's one study which was reported in pediatrics. There are more than 50,000 infants in 127 NICUs in California. So the variation in antibiotic use was 40-fold. This is very surprising. This could not be biological variation. This has to be in the environment, the social context where the antibiotics are being used. So the antibiotic use was as low as 2.4%. I would call it excellent, to as high as 97%. Almost every baby was exposed to antibiotics. The median value was 24.5%. And the antibiotic usage surprisingly was independent of proven infection, necrotizing enterocolitis, the surgical volume, or the mortality rate in the unit. That means, okay, the infection rate is high, so we tend to use antibiotics, but there is no direct correlation. Prescribing antibiotics is a very complex human behavior. It takes into account not only the rate of infection, but the awareness on the part of the treating physician. The setup where the person is working in the government setup or in the private setup, the vulnerability of the baby. So no wonder there is a clear-cut disconnect between culture positive sepsis and the culture negative sepsis and using antibiotics. Can I have next slide, please? So what steps we can take to curtail excessive antibiotic use? Of course, antibiotic stewardship. It helps curtail excessive antibiotic use in NICUs. So QI initiatives can play a big role. The people have found that 20 to 40% reduction in the rate of antibiotic usage. Education regarding the risk of broad spectrum antibiotics use. The antibiotics are helpful, but they can also kill. They can increase the cost of care. They can prolong the stay of the baby, and the side effects are more. We need to have guidelines for antibiotic use. But my point is, no point in having guidelines unless they are implemented. In our own hospital in BHU, we have so there was a directive from university that you should have guidelines for like the medicine, surgery, obs, gynae, or pediatrics, NICU. So we framed guidelines, but in many places, those guidelines were not implemented. So we need an audit, prospective audit and feedback. Unless we audit what we have done, we will never be able to improve. I think this is my last slide, or maybe one more slide is there.
No, I think this is the last one. No.
Yes.
Okay, fine.
Okay. So antibiotics stops on empiric antibiotics, an automatic stoppage after 48 hours. And you need a new order to, if you need to continue antibiotics, but it may be difficult to implement. Sometimes there is a clear-cut disconnect between preaching and practicing. And sometimes it also applies to me. We can have a sepsis risk calculator. I'm not aware, do we have it in India or not, though one can use it with what is available. And maybe use of biomarkers to some extent help us in selecting or in deciding should we use antibiotics. But in a complex situation like neonatal sepsis, where the baby is fragile, sick, no clear-cut evidence, even then people would tend to use antibiotics. Unfortunately, sickness is equated with septicemia, or sick baby or septic baby. these things are difficult to disentangle, but still I think we can do a lot to curtail the use of antibiotics. And the last point is, even if we start antibiotics, baby improves remarkably, then we should be strong enough to stop antibiotics after 40 to 72 hours when the biomarkers are negative and the culture is also negative, and provided you believe your lab. That is also very, very important. So thank you very much.
Thank you, Dr. Ashok Kumar, for giving a very nice insight as to what we should do when we find this. I think whether we have an AMS program or not, first of all, we should have one. But even if we have one, Dr. Ashok Kumar said that a lot of people do not, I mean, it's not implemented. So it has to come from within the unit. And I think whenever we go on rounds in the neonatal unit, our job not only is to take care of the babies, but to decide how many antibiotics can be stopped, how many antibiotics can be de-escalated, how many IV lines can be removed, how many babies can be discharged, how many baby can go on to breastfeeds, etc., etc. So we need to learn to de-escalate and not keeping on escalating. So with that, the next question to Dr. Bharat is, an outborn neonate has been referred with meropenem. Neonate is clinically doing well. Sepsis screen in your place is negative. Your unit policy for outborn neonates is peptase amikacin. So what will you do?
A very appropriate question that we encounter very commonly in our referral units. First of all, empirical antibiotic use means you start antibiotic empirically. You haven't come to a definitive diagnosis, but based on clinical features or scenario, you have started antibiotics. So how do we come to an empirical antibiotic? Like, how do we decide empirical antibiotic? Ideally, it's based on your collection of last 4 to 6 month data. That is what we call antibiogram. Based on that, we decide what all antibiotics to be used in our unit. Suppose in a scenario like this, where you get a certain more number of babies from one of the extramural center, and you already know by your antibiogram that this extramural center has lot of multi-drug resistant bug. So in that case, if you already know this baby is coming from that hospital, you may still continue with meropenem till you get your own results. Another scenario where I would like to still continue with meropenem, if the baby is clinically looking very septic or baby is very sick, like in shock or severe respiratory distress, I may still continue with meropenem. But unlike the other two scenarios, in this case, it is highlighted that baby is clinically doing well. So as per our antibiotic policy, we'll screen the baby, we'll send the blood test that includes your sepsis screen, blood culture, and you do lumbar puncture or radiological test based on the clinical scenario. Then once you get all the reports, you classify the scenario, like whether it is definitive sepsis, possible sepsis, or probable sepsis. Based on your categorization, you target your antibiotic strategy, like how many days you need to give. Like for definitive sepsis, you may still want to give for 10 to 14 days. In that case, if culture is positive. So that's how you decide your target plan of antibiotic duration. Coming to concept of de-escalation, de-escalation means you narrow down the antibiotic. You come down to the spectrum which is very narrow. Like you come down from broad spectrum antibiotic to narrow spectrum. Like you begin with meropenem, you now come down to piperacillin or ampicillin based on your culture sensitivity spectrum. De-escalation is a safe practice. It's not like that if you de-escalate, antibiotic baby is going to deteriorate. So believe in your labs, believe in early exit policy. If all is doing well, you can always de-escalate. So like if a culture report shows a gram-negative bug, then you need not continue vancomycin. You can safely stop vancomycin. This is also a part of de-escalation. So de-escalation basically means you either narrow down to the narrow spectrum antibiotic, which has got least adverse effect, least safety, more safety, and obviously it will be less costly. So you come down to the minimum course, duration, as well as the antibiotic. So that's all about de-escalation.
Yeah, thank you so much, Dr. Bharat. Very well said that we can definitely, if this baby is doing well, we can certainly consider de-escalating. But if the baby is sick, obviously you may continue till your reports are available. We will not go into antibiotics, and after antibiotics, what happens to the culture, that's a totally different discussion. Okay. The next question is to Dr. Ashwini Sood. Last 6 months data of an NICU shows a significant increase in the incidence of multi-drug resistant organisms. necessitating the use of third line or reserve antibiotics. So auditing shows increased use of reserved antibiotics. What strategy will you use to solve this problem?
So, Dr. Lekha, as you said in the beginning, that first and foremost will be the infection prevention, control, and hand hygiene. And rightly, this COVID has also given us more and more insight into hand hygiene. And I think, and my experience to begin with, I started my career, hand hygiene is one of the most important factor which is missed in the ICUs, especially both in NICU and PICU. So one need to take care, and because most of the time, if we look into the data which is there, this multi-drug resistant organism are transmitted even by the healthcare personnel also in the intensive care setting. So unless I take care of hand hygiene, and I set an example to begin with as I enter the unit, only then my whole of the unit is going to follow that. And with that, in addition to that, in addition to infection prevention, I'll try to look into, as Dr. Ashok and Dr. Bharat was saying, I'll do an audit that why I'm seeing these multi-drug resistant bacteria, because if you go into the literature, it has been said rightly that if we use, misuse rather, overuse or misuse broad spectrum antibiotic, we are going to have more and more of multi-drug resistant organism. And that also leads to more of NEC and other issues in the, especially in the NICU. And secondly, as we need to de-escalate, we need to look whether we are de-escalating, because at times we find a baby sick who has been referred. One need to, we call in antimicrobial practice as to hit hard. So definitely we are going to use at times 2 antibiotic, but as Bharat has rightly highlighted, that once we get those cultures and use of other reports, one need to de-escalate, because it is shown that if we keep on prolonging the duration of empiric antitherapy, especially in low birth weight babies, extremely low birth weight, we have more risk of NEC or late onset septic, and this is also going to lead to prolonged stay in the hydrate. Very important is because what happens at times in emergency, the residents, they just use the antibiotic which is on their pen. So one need to, before we starting these writing, so there has to be clear-cut policy in the unit, in the hospital, in the institution, and ideally, as madam you said, that for reason-wise, there's a right, very right point to have prior authorization of resisted antimicrobials. Only then we can take care of these multi-drug resistant organisms, because if we have policy of pre-authorization, it has been shown to improve the use of restricted drugs, which we can curtail to a point. But at times people find it objectionable also, because it is going to impair their autonomy as a prescriber, and sometimes it may lead to delay in the drug administration. So this is one of the point in antimicrobial stewardship. And with this, what I like to make one brief comment that as we get new residents every year, we need to sit down with them and talk about antimicrobial stewardship, resistance, and it's important to understand the PK and PD of all the drugs which we are using. So we need to have this restricted antimicrobial policy, and then again that we need to use, or sometimes need to look into the alternative one. So next part of this question is that how we are going to take care. So there are certain golden rules. I have put them very briefly, just some of whichever this panel, my colleagues in the panel are discussing. So whenever we get optimum microbiology report, we should be taking them to use our further therapy. And whenever we are going to use antibiotic, kindly try to look into some evidence-based guidelines. And just to continue with Bharat, narrow spectrum. And very important is to doses must be appropriate to site and type of infection. That is, I should be using knowing PK and PD of all antibiotics. Minimum duration of therapy, if I find 5 days is good enough. And if I find that I'm comfortable with monotherapy, that should be the choice. And that is actually, before that, we need to have commitment. Everybody should be aware that this is one issue where one need to work, and so that we reduce the hospital stay of these sick neonates.
Thank you so
And
much.
the golden rule is right drug, right choice, and the right route. With this, if we use when antibiotics are not needed, probably as we started this discussion, the day is not far away when we will not have any antibiotic in our store when we will need them. Because we know that in last 10 years, only 2 near antimicrobial has been launched. So we are in that this pipeline also dried, because there are a number of factors which we can discuss later on. So this, as Dr. Ashok pointed out, this stewardship is a team game, and we need to work as a team in our unit and in our institution.
Thank you so much, Dr. Ashwini, for that. Rajat, you had a comment?
Very specific point I wanted to make. See,
Yeah.
one of the reasons why we end up with MDR, and especially in intensive care units, is overexposure to cephalosporins. So there's something, I mean, if we read about how bacteria cleverly develop antibiotic resistance, one of the important things is something called as AMP-C gene. So all our gut organisms, Enterobacteriaceae, carry this AMP-C gene, which will help the bacteria produce beta lactamases. And it is dangerous for two things. One is that if the bacteria did not need cephalosporin, if you kept giving this cephalosporin to the baby, the AMP-C gene gets amplified. So, and the second very worrying thing is it's plasmid transmitted. So an E. coli sitting next to Klebsiella, sitting next to Enterobacteriaceae, all of them within a span of time will become cephalosporin resistance. And this is just one more step from carbapenemase producing genes. So I think if at all we want to do something about this, one other thing is just look at your empirical use and overuse of cephalosporin, not only in NICU, but also in the pediatric wards, because you know, bugs can travel from PICU to NICU, you know, with along us. So
Thank
cephalosporin.
you. Thank you very much for that comment. But I'll just digress a little bit. One of my favorite comments, that I don't think the same person should be taking care of PICU and NICU. Sorry. I know it's economically, practically not feasible. And I know there are training units where they train for neonatal and pediatric, but I think our neonates need to be a little more separate from our children, and children needs to be a little more separate from our adults. Okay. Dr. Arjit Mahapatra, you have audited the antibiotic use in an NICU and find that, I know this has been covered, but I just want you to re-emphasize that. You find that a lot of prophylactic antibiotics are being given. It's being given for everything, every intervention, the baby is on antibiotics. How will you go about reducing the use? I want a practical answer, that what steps will you take to reduce the use of prophylactic antibiotics? The last question.
Yeah, it's been already discussed with almost all the speakers, that first and foremost is developing unit policy of usage of antibiotics. Like the case scenario you gave, an outborn has come and what antibiotics to be given, or for that matter, interventions means simply putting an IV line, maybe an intervention. So we need to develop a policy who gets the antibiotic in the first place and what antibiotics in the first place. So first is no antibiotics. Second is the lowest possible antibiotics. Third is the least possible period of time. And most important is to de-escalate and the courage to stop the antibiotics, just for not to be used just for that the baby in NICU should get some antibiotics. So we have to develop that policy, and more important is that mindset to go about it.
Thank you so much. Thank you so much, Dr. Arjit. And I like that statement you made, the courage not to use antibiotics.
Yeah.
The last question is to Dr. Suhail. Again, it's a repetition, but I still think we need to keep motivating ourselves. How do we motivate people to use less antibiotics? How do we give them the confidence and the courage to use less antibiotics? And I like the word somebody used during the session about peer pressure. I always used to think peer pressure was for school children. You know, the birthday parties and things like that. But I wasn't sure that we have also peer pressure. And I think I realized that, yes, we do have peer pressure. So please tell us how to motivate all of us to use less antibiotics very quickly.
Peer pressure is a very big thing, ma'am, especially in the two-tier cities. I don't know what the metros now.
Little loudly, Suhail. Little loudly.
Ma'am, creating awareness is a first foremost thing that we need to say. We need to make people aware. Like we saw that when Corona came, with every call there was like that. We need to do something with even at tea meets, whenever we go out for we meet doctors. We need to keep discussing about this antibiotic resistance and antibiotic stewardship programs. Awareness will be the one thing which will help us in tackling this issue. And after awareness, like we need to involve more and more personnel, whoever it is, right from the consultants and then infection control nurses, the regular nurses in the NECO and PICU, even in the wards, and then then we'll have a better this thing. Like I'll just give you an example. I was there for the workshop 2 days back, and I had given one of my colleagues to take care of my babies, and that baby was not on antibiotics, and a mild amount of distress, but baby looked like a transient tachypnea, and I just had to leave. And the consultant ordered for an antibiotic, and the moment the consultant went out of the rounds, my nursing staff called immediately saying, "Sir, an antibiotic has been prescribed. Should we go ahead?"
Super.
So this is how we need to train our nurses also. The moment that they see an antibiotic, they feel that yes, it is something like oxygen which is being given to the patient. So the moment we start, we are sure that by what time we will be taking it out, or more like we can say as soon as we put it on a ventilator, we should think of antibiotics in that sense. The moment we put a patient, a baby on a ventilator, we start thinking that how we are going to de-escalate and take the baby out of the ventilator. So this is how this awareness and talk among people is going to the most important factor. And then next, repeated unit meetings, like at least if not monthly, 2 monthly or 3 months once, we keep updating our unit and see what the antibiogram says. So the more frequently we meet, the more personal we involve, there'll be a sense of responsibility and the self of belonging of that person who is being involved. So the moment you involve more people who are aware of this antibiotic stewardship, and every time while giving an antibiotic, even we discussed about microbiologists being involved, we discussed about statistician being involved. I personally feel we should also take the pharmacy person inside, where we involve him in these meetings, so he also knows how serious we are about antibiotic use. So once that is there, even while giving, and sometimes when and just out of the routine some antibiotic prescription comes, he also calls you up and then tells sir, this antibiotic is being prescribed. So we are aware of what all antibiotics are going on in our units. And then frequent updation is most important. Like Dr. Rajat was saying, we form a policy once and then just leave it, or we form a policy and we don't follow it. This will not be helpful. So we need to be every time motivating people, like you tell, you especially boast of the newborns which you have not given antibiotics. Like there was a 30-weeker who stayed in the hospital for 2 weeks without an antibiotic, went home happily. There was a 28-weeker who stayed in 6 weeks in an ICU and we didn't use antibiotic, they went home happily. So we need to start boasting of such achievements where we have not used antibiotics and babies have gone home happily. Especially when, as we were discussing, there are entities where a sick baby, we take it as a marker of sepsis, which is not the case. So whenever those who are taking the lead and we are not using antibiotics, we need to boast of such things in front of our colleagues, so that they also feel happy that yes, such a thing can happen. Because nowadays if you see people, they feel babies can't go out of the NECO or PICO without having antibiotics, which is not the case. So colleague, like we were just speaking of peer pressure, even peer encouragement is will be a most important factor which will help us in tackling this issue.
Thank you so much, Dr. Suhail. Thank you so much for highlighting the ways we could decrease antibiotic use. Can I have the last slide, please? Oh, sorry, I only have to do the last slide. All right. Yeah, I think these were your slides, but it's okay. You have covered all these points. Sorry.
Yeah.
Okay. So I think to sum up, antimicrobial stewardship program is needed to reduce use of unnecessary antibiotics and to reduce antimicrobial resistance. It is not easy to set up an AMS. It is not easy to implement, but it needs to be done and it needs to be sustained. We have discussed this. Auditing is an essential component and this should be ongoing and we should keep on having a feedback of this. We need to train ourselves and all other healthcare personnel to respect and conserve antibiotics and antimicrobial agents. QI initiatives is the buzzword now, and I think we need to use this opportunity of the popularity of QI programs to reduce our antibiotic use and to give confidence to healthcare personnel, to give them courage. We have to improve our infection control practices. I keep repeating this last statement that I'm going to make wherever I talk about on infection control on antibiotic. After leaving St. John's, when I went to another hospital, the NICU had only multi-drug resistant organisms and fungal infections. And with a year of hard work, so it's not going to happen 1 day, 2 days, 5 days, 1 week. With a year of hard work, the next year's audit showed absolutely no multi-drug resistant organism. And that was possible only by being a dictator, a friendly dictator sometimes, and a very stern dictator sometimes, and networking with people in the institution, the nurses, patting them on their back when they do good, pulling them up when they didn't do correctly, involving the infection control unit, and taking the help of the administration. So we need to network, we need to involve, but I think the most important thing is that we need to be convinced that we need to reduce antibiotic use and antimicrobial resistance. Thank you so much to the panelists and thank you to the organizers.
Thank you, ma'am, for that wonderful talk. I think this discussion served its purpose. It scared us, it taught us, and it almost reassured us. And hopefully in the future, we will still have some antibiotics. Thank you. Ma'am, we would like to request you to extend a token of appreciation to our panelists present here.
Sure.
Dr. Rajatatreya.
Sorry.
Thank you, sir. To Dr. Bharat Sukija. And we would like our panelists to give the certificate and bouquet to ma'am as well. Dr. Rajat, please give our moderator the certificate. Thank you, sir. Thank you, ma'am. We would now like to request all the participants to kindly move to Hall A, where we will be having the NNF oration. It will begin at 10:35, and we request you to make your way there. Thank you for your cooperation.
Yeah.
Hello.
Hello. Hello. Hello, Mr. Chandra. Hello. Hello,
Hello?
Mr. Chandra. Can you
Hi,
hear me?
sir.
Hi, Namaskar. Are you, am I audible
Yes,
and
I can
visible?
hear you. Hi, namaste, sir. Yes, you are audible. Yeah.
Thank
I'm
you.
actually doing for virtual as well. I'm not in the conference.
Achha, you are also virtual?
No problem, sir. I am also virtual. Yes.
Okay. Great.
I did the workshop. I was there fully.
Okay. Which place you are from?
Bangalore, sir. Motherhood Hospital.
I'm not. Your voice is.
Bangalore. I'm the HOD and the consultant here.
Okay, great. No, not audible exactly.
Not audible. Huh?
The voice
Okay.
is
Maybe I'll have to
breaking in
change the
between.
place. Okay, this has been the problem, sir, all the time. Virtual workshop.
Okay.
All right.
Hopefully, Madam Rita Bora should join now.
Should join. Yeah. And usually they're running a little late there, and it is the lunch hour there, I think, in the conference.
Okay. So there will be hardly much crowd. That generally happen in most of these conferences.
Correct, sir.
People are busy in other activities rather than
absolutely right. Absolutely.
And so much of activities are going on.
Correct, sir.
At times you feel there's a pandemic of webinars and all these.
That is true. Where are you from,
I am
sir?
actually I am from army. I am an army veteran, and after doing my 32 years of service in armed forces as a pediatrician and a neonatologist. I had I'm presently at School of Medical Sciences and Research Center, that is Sharda University, Greater Noida.
Right.
So
Okay, sir. Okay.
It's a post-graduation institute here. So
Yeah.
so that is
Very
how.
nice, sir. Very nice.
And
Nice
what
to
about
talk
you?
to
I
you,
couldn't
sir.
get. Where are you?
Sir, I am in Bangalore, sir. Bangalore.
Okay, great.
So this is where the conference is going on anyway.
Yeah.
But today I had this thing, inspection for the level 3 NICU inspection.
Okay.
So that is why I could not go physically.
Okay.
And the people who have come to Bangalore, they're just doing the inspection. They're taking the opportunity to finish off the inspection for the NNF accreditation.
Yeah. I can Bangalore. Secretary General is from Bangalore only. Happy, and yes, put the things too much of DIP activities. Dr. Basavaraja sir.
Dr. Arpana. So we have with us a few panelists. I'll request you to kindly call them. Panelist.
I request the panelists to kindly join us on stage.
I am already there, ma'am. Good afternoon.
Good afternoon, sir. Are you able to hear us?
Yeah, I am able to. You are audible
Thank you, sir.
nicely.
Good afternoon, ma'am. Dr. Pratap Chandra here. I'm also here and I'm able to hear you.
Thank you, sir.
Hello, hello.
Yeah, okay. Yeah, we have with us Dr. Pratap Chandra.
Yes, ma'am.
Yeah, and Dr. Sandeep
Hello.
Kadam would also be there as a panelist. Then we have Dr. Sanjay Gharpore with us. Yeah, we move on to the next slide. Dr. Vishwanath Kamoji. And also we have Dr. Jayachandran from Kerala. So, yeah, then we have Dr. Rajiv Thapar from Noida, Greater Noida, Delhi.
I am available, ma'am. Thank you. Good afternoon.
Good afternoon. And Dr. Pratap Chandra, we have already mentioned, he is also there.
Yeah, good afternoon, ma'am.
Yeah. So to start with the discussion, so we have rare maternal infections as a topic today for the panel discussion. And these infections, which are not very common with us, can be transmitted in different ways, like congenital, peripartum, or postnatal, when they get transmitted vertically to the newborn. The prevalence is not exactly known. There have been some studies from different parts of the country. And one very recent study, which was published in 2020 from Jabalpur, they mentioned about a study which was done in 144 mothers who had come to the high-risk clinic. And they found that the most common seropositivity was there, IgG seropositivity was there for cytomegalovirus infection followed by rubella infection. And they also found that almost 27% of the babies born to these mothers when they followed up to delivery had congenital malformations, and most common was cardiac malformations. Now, it was also mentioned by WHO in 2015 that Southeast Asian region has high endemicity for congenital rubella syndrome. Low socioeconomic status, poor education in the community, and lack of universal vaccination and healthcare facilities may be the cause for high prevalence of seropositivity. So now to start the discussion, I would request Dr. Sandeep. So we go to the next slide. Move on to the next slide, yeah. So I would request Dr. Sandeep to kindly answer which are the neonates in whom we should suspect congenital infection, and what are the common congenital infections that we encounter in our clinical practice? Dr. Sandeep. Are you there? So probably he is not getting connected. So the common flus which occur for torch infection are in the history. So we need to take a proper maternal history. So there can be a history of fever, rash, lymphadenopathy. And the neonate may sometimes present with growth restriction, rash, fatigue, lymphadenopathy, hepatosplenomegaly, hearing loss, chorioretinitis, cataract, microcephaly, ventriculomegaly. Sometimes there is blueberry muffin because of extra medullary hematopoiesis. And then cardiac malformations like PDA or intracranial calcifications in certain congenital infections can be present. So the common infections, as I have mentioned already in the introductory point, is most common is cytomegalovirus infection. Then we also see toxoplasmosis. herpes, as well as rubella. So next, I'd like to ask Dr. Kamosi, in a patient with congenital infection, what are the clinical pointers to say that congenital syphilis is present? Now we have known that there are certain common features, but are there any features which would suggest that this baby is suffering from congenital syphilis as well as for congenital herpes infection?
Thank you, madam. And thank you everyone here sitting and listening to us post lunch. Now, congenital syphilis, I'll give you two examples. One is a lady who's come to the skin VD department who is found to be positive, and she has been referred to the obstetrics team for further management. Now, any symptom this baby develops at the end of term will be attributed to congenital syphilis. But again, can we get to the slide? Again, we have plenty of symptoms which may not be related to syphilis. We have this baby who's got some purulent discharge. How many of us see discharge in newborn babies and discharge in 3 months, 4 months age baby? We don't think of congenital syphilis in those situations. When a mother is asymptomatic or she has somehow not come to the fore with the symptoms, we do not know what the story is. If she has not had any serology done, we are blind to what the baby is presenting. Today, sitting here and looking at this photograph, we may say, yes, this is congenital syphilis. This is typical of congenital syphilis. But it is extremely difficult to diagnose congenital syphilis, and we have to have a strong, suspicious mind to pick up small clues. If there is a persistent rhinitis with mucopurulent discharge, and the baby is jaundice, having hepatosplenomegaly, keratitis, and cataracts, we may think as one of the differentials as congenital syphilis. Another clinical pointer is at birth, there is phenicitis. Now, phenicitis is different from omphalitis. Phenicitis is just inflammation of the umbilical cord. Along with that, if you find significant desquamation and blistering lesions of the hands and soles and punched out lesions on the ears and nasal bridge, you possibly think of congenital syphilis in those situations. Now, we have early congenital syphilis and late congenital syphilis. Now, the symptoms of early congenital syphilis can manifest up to the age of 2 years. So it is not banged over that the syphilitic symptoms may start in a couple of months or couple of weeks. It can last much longer. But these are some of the symptoms which we can think of, which may lead us to think of as a differential at least of congenital syphilis in the presence of high maternal contact history and serology. Congenital herpes, again, a lady coming with cold sores and vaginal rashes, delivers normally, and the baby develops any symptom, we attribute it to congenital herpes. Generally, the vertical transmission is very rare in about 5% of the times, and this baby presents with congenital at birth vesicular rashes, skin atrophy, CNS manifestations, and retinitis. But most of the times, mother is asymptomatic, though she's shedding viruses, but she remains asymptomatic. And this baby may present to us with rashes. These rashes could be single or in group, and commonly it presents in the first 7 to 10 days of life with oral mucosal eye lesions called SEM lesions in about 50% of patients. But mind you, they may not be present at all, and the baby might straight present to us with CNS and disseminated infection. So we should have a strong index of suspicion for any baby who is presenting from a week to up to 6 weeks, some say up to 6 months, in a baby who's presenting with clinical rashes, CNS symptoms, and transaminases. So these are some things which will make us feel that baby probably has congenital herpes infection.
Okay, thank you. So my next question is to Dr. Jayachandran. What are the clinical pointers suggestive of congenital cytomegalovirus infection in a newborn?
Thank you, ma'am. There are a wide range of clinical features associated with the congenital CMV. The most common amongst them are skin rashes like purpura, petechia up to 80%, organomegaly 75%. Very common to have jaundice, conjugated jaundice. They can have respiratory problems with pneumonitis. There will be microcephaly, there will be IUGR, they'll be having abnormal CBC, abnormal LFT, and clinically symptomatic one, they got high mortality also. That's the initial stage. At later stage, they can manifest with sensory neural hearing defect, CNS problems, or visual problems. This is what I talked is about the congenital infection. We also want to know about the postnatally acute CME, which is also not uncommon. It can be transmitted by breast milk, by close contact with the positive mother, and also by blood transfusion. But normally it manifests after a month or weeks later with sepsis-like problems. It may be confusing with other bacterial sepsis, but neurological abnormality is rare after the postnatally acute CMV ones.
Okay.
Thank you.
So now I'd like to ask Dr. Sanjay, would we be able to diagnose a patient with congenital toxoplasmosis clinically? Can we suspect it?
Yeah, thank you, madam. Basically, when we are discussing the congenital toxoplasma, it is basically a sequelae of the maternal infection. That means there must be history of the maternal infection, number one. Then in the mother, there may be history of contact with cat or eating raw food. You may or may not get. Third important part, when is the infection? If it is an early part of pregnancy, more severe will be the congenital toxo symptoms. If later in the pregnancy, though disease spectrum is more, severity is less. Again, the immunocompromised or immunocompetent mother, that will be deciding factor. If the mother is immunocompromised, definitely the disease what develops in the neonate will be the more severe. While in fact, in immunocompetent, the disease will be less severe. Now, how is the clinical presentation? Majority cases are asymptomatic. Hardly 10 to 30% cases may be symptomatic. And classic triad, that is hydrocephalus, intracranial calcification, and chorioretinitis retinitis. These are the hallmark of the diagnosis of the basically congenital toxoplasma. Apart from that, you can get the other symptoms like a regular torch infection, hepatosplenomegaly, anemia, thrombocytopenia. There may be history of stillbirth, IUGR. Then sequelae can be present that undiagnosed case, or in adolescent, they may be facing the problem of precocious puberty or intellectual disability. So these all things you can get. Also, sometimes there may be just you can get history of stillbirth or recurrent abortions. And by screening, you are noting that mother is suffering from the toxo, and that's why there are so many previous pregnancy losses. So like that, this is a classic IUGR baby that can happen after the toxo infection, which we can label as a congenital toxoplasmosis, and that may lead to blindness apart from all the congenital defects.
Okay. So now, Dr. Raziv, if you are
Yes.
online. Yeah. So can we suspect congenital rubella syndrome then?
Thank you, ma'am. Thanks for NEOCON team. My answer will be probably yes, we can suspect, and in our practice over the long years, we have seen such type of cases. Basically, as Sanjay sir has said, it is a clinical suspicion that we have to make a strong clinical suspicion in such cases, which may have overlapping symptoms. Overlapping as I will also be discussing a similar type of features as Dr. Sanjay has mentioned for the toxo. So basically, if we look for the rubella, it will be a congenital heart disease, which may or may be associated with hearing impairment. Now with the newborn hearing screen, we are getting babies who are maybe having some sensory neural hearing loss. And then one or more of the following eye signs, maybe cataract, maybe congenital glaucoma, and salt and pepper chorioretinitis. So such type of combination, if we get phenotype, such type of combination which we get, we can surely label them as rubella syndrome following rubella, maternal rubella infection. So in case of suspected congenital rubella syndrome case, basically the classical triad is the heart disease, hearing impairment, and one or more of the following signs, that is cataract, glaucoma, or retinopathy. Somehow it is also mentioned in the literature that if the infant's mother has a history of suspected or confirmed rubella during pregnancy, a clinician should suspect congenital rubella syndrome even if the infant shows no signs of CRS at the time of birth. They need to be followed up for sensory neural hearing loss, the psychomotor retardation, the mental retardation, the development of cataract. Next slide, please.
Sorry. Can you come?
Basically, we have to have a clinically confirmed case.
Slides have disappeared. No? So, yeah, so we have learned now that most of the conditions which can manifest as congenital intrauterine infection, be it cytomegalovirus, rubella, or other infections that we have mentioned now, they have certain overlapping syndrome, clinical manifestations. But when we take the history properly and look at them closely, there would be certain subtle clinical findings which would help us in pointing at, out at the exact diagnosis.
Basically, basically, we should have this two types of groups of cases, which at least two of the following complication listed in group A, or one in group A and one in group B, so that amalgamation of these two findings, maybe we are able to label them as clinically, and then we can go for the investigation part. Thank you. These are some of the additional clinical signs which may have overlapping with other congenital infections, as has been pointed out by previous panelists, that jaundice, low birth weight, development delay, microcephaly, and dermal erythropoiesis leading to blueberry muffin skin lesions.
Okay. Now, there are certain conditions which we do not see very frequently, like parvovirus B19 infection, HIV, and also chickenpox. So I'd like to request Dr. Pratap to tell us if we can suspect these conditions when they are present congenitally, clinically. Dr. Pratap. Is it there?
Am I audible now?
Yeah.
Yeah. Okay. So basically, I'll just take one by one. Congenital parvovirus B infection. Whenever we have seen a fetus or a baby with non-immune hydrops, almost 10% of them have had parvovirus B19 infections implicated in non-immune hydrops. So whenever we are doing the the ultrasound scans, we can detect as early as 18, 20 weeks when babies started developing these hydrops. Hydrops is nothing but having fluid in two or more compartments. And the reason this happens is parvovirus B19 has got predilection to your erythrocytes, and then it will suppress the erythrocyte production. And then that results in very severe anemia. And this is the reason why a baby can develop congestive cardiac failure, as well as the hydrops. So if I go to the next slide, where there is, sorry, one slide before, ma'am, this is the way that they detect anemia is they look at the middle cerebral artery Dopplers and the peak-systolic velocity of the middle cerebral artery Dopplers. And if it is high, that means the blood is very thin. That means it is anemia. And majority of these cases are detected by that. And generally, the consensus is don't abort these babies. They might need, in utero transfusions, maybe one, maybe more than one in utero transfusion in order to prevent going into the hydrops. So that is B19 infection. Then if you move along for the HIV infection, obviously this is only known if there is a mother who's known case of HIV infection, whether she's undergoing treatment or this is the first time when they do the antenatal screening, she is diagnosed with HIV infection. Whenever these babies are born, if the HIV status is not known in mother, majority, almost all of them will be asymptomatic. So there is no way that we can actually detect this thing based on the suspicion. So most commonly, HIV infection suspicion comes because of known case of maternal HIV infection. So moving on to the varicella, overall, if you look at it, the transmission risk is very, very low. And in here, again, there are two things which can come in. One is congenital varicella infection, where usually the exposure for the virus happens within the 13 to 20 weeks of gestation. In these babies, they tend to develop what is called as the congenital, varicella syndrome. If you can move on, ma'am, next slide quickly.
Yeah, Dr. Pratap, we'll have to be a little bit quick because we have already completed 15 minutes. So.
Okay. Fine, ma'am, fine. So basically, that's how you suspect. And secondly, if a mother has got, the rashes herself and then the infection in the peripartum period, this is when the baby is supposed to develop more severe infections in the postnatal period, which I will discuss when I come to the last slide. Okay, thank you. So this is how we should have a strong index of suspicion. This is a slide to show some of the features of congenital and cicatrical skin lesion. Thank you.
So Dr. Jayachandran, how common are Zika, H1N1 and dengue infection congenitally, and can we suspect them clinically?
Yeah, as the talk itself says, these are not very common. The exact incidence is not clear, but it's affecting at different endemic areas in different climatic conditions. Like H1N1, the flu is more common in winter months in Europe, like that. So let me go through the clinical features of each infection. The previous one, please.
Previous, okay.
Yeah, the congenital Zika, the great risk is happen when this infection happened the first trimester, like any other problem. They got significant clinical features. The baby will be in really bad shape with microcephaly, facial dysmorphism, abnormal tones, seizures, irritability, eye problems, hearing loss, and they have abnormal MRI, and they are high prone to develop severe neurodevelopment disability if it happened in the first trimester. And coming to congenital dengue, they can pass the virus to the fetus if she develops fever 10 days before the delivery, and the average time between fever and symptom to the baby is 7 days. And it's highly risky in young mothers when the dengue antibody level is high, and neonatal dengue is more serious in preterm or low birth weight infants. Clinical features: fever, rash, thrombocytopenia, abnormal liver functions, and rarely dengue shock syndrome, which can be very serious.
Okay.
And coming to H1N1, again, more problem if the infections happened in the first trimester. They can, if the baby is affected, baby will have a neural tube defect, hydrocephaly, heart disease, cleft lip, and limb and digestive system problems. And then also increase the risk of abortion and preterm delivery. And pregnant females receiving inactivated influenza vaccine, not live vaccine, can reduce the incidence of poor neonatal outcome. And any lady or postpartum mother, if she suspect to have or confirmed influenza, should start antiviral therapy as early as possible, irrespective of the vaccination. Thank you.
Okay. So as we have already discussed, although we usually have an acronym called TORCH to describe congenital intrauterine infections, there have been many other infections which can occur as congenital infection, and many symptoms can be overlapping between the different conditions. And we need to take a very careful and appropriate history and do a clinical examination so that we can actually point out which is the infection that is occurring in the individual baby. And this is important because we want to avoid unnecessary investigations so that we also avoid expenses, and also we can go for treatment which is available for some of the conditions, and also we can prognosticate. So next, I would like to ask Dr. Sandeep, what is the significance of use of TORCH panel for diagnosis of congenital infection? Now we have suspected clinically, so would you go for TORCH panel for diagnosis?
Thank you, madam. Am I audible?
Yeah.
Yes, yes.
Yeah. So, madam, there was a strategy where people, when there was a practice of doing IgG in all the mothers with any bad obstetric history, and they used to label this as a TORCH panel, or suppose there was some unexplained IUGR. Actually, doing TORCH panel just tells us about the IgG antibodies in the mother. It just tells us that the mother's immunological reaction as to whether there's an immune response to the past infection. And it is not helpful in the diagnosis of TORCH infection as far as the baby or this baby is concerned. So as of today, I think what we really understand is that doing TORCH panel is not worth, it just tells us about the immunological status of the mother. It tells us about the IgG antibodies, but it may not really help us in the diagnosis of congenital TORCH infection in the specific pregnancy or the specific baby. And what we really need to do is to look at the baby, have a clinical scenario, and then do a specific focused test depending on your clinical suspicion rather than doing a panel.
Okay. So again, now I would like to request Dr. Kamuzi to tell us how we diagnose congenital syphilis. Do we need to do only confirmation test? That is enough, or we need to do certain more tests? And also regarding herpes infection, how would you confirm the diagnosis? So I would request all the panelists to make it short.
Sure, we'll do that. Now, confirming congenital syphilis is not easy, full stop. It has to be done in certain way. There are two types of tests. Can you go to the next slide, please? Non-treponemal and treponemal test. Now, the non-treponemal tests are the screening test, which is RPR and VDRL. If it is reactive, we go to the treponemal test, which when reactive tells us that the baby and or mother has syphilis. Now, these titers must be shown to be 4 times normal of what mother has. Only then we can confirm it as congenital syphilis. And when you do is depending on when the baby presents with symptoms. Of course, if the mother has come with VDRL being positive, we do it fairly soon after birth, but sometimes it can be missed. Can we go to the next slide, please? Other than the treponemal test, if it is strongly suspicious, we do PCR of placenta, cord, lesions, or body fluids, and silver staining can help. If strongly suspected, PCR of the CSF is very helpful. And in later time, X-ray of long bones count and other investigations, including CT scan, MRI, may be needed to diagnose congenital syphilis. Once a baby is presented, this is about herpes. Once a baby is presented with rashes, convulsions, and increased transaminitis, we had to take plenty of samples. These samples are surface samples from the skin, from the vesicles, nasopharynx, oropharynx, and send it for PCR assay. We also send the blood for PCR assay. And because the baby is presenting as sepsis at that time, we should always remember that we rule out sepsis markers, do some blood tests to check the transaminases to confirm whether it is the viral infection. And in certain cases, we may also end up doing metabolic causes because the baby is presenting at that stage.
Okay. So Dr. Jayachandran, what test would we do to confirm congenital cytomegalovirus infection?
In simple words, the confirmation is only by doing CMV PCR in blood, urine, or saliva. The most commonly used, we use urine. We can also do viral culture in urine, but it's more time consuming and expensive. And as Dr. Sandeep already mentioned, just simply by doing torch is not confirmatory about it. If you got both IgG and IgM positive and titers are increasing on repeat test, that's more informative. If you want to identify recent infection, low maternal IgG ability may be helpful. And to find out the other associated clinical features, MRI brain is useful. We need to check the eye and hearing evaluation and simple tests like blood count and LFT. Okay. Thank you.
And Dr. Corpore, how would we diagnose toxoplasma, confirm the diagnosis? Clinically, we have already done it.
Already in the previous discussion, we have discussed the triad. That means basically intracranial calcification and hydrocephalus very well. The imaging is most important. Even simple CT scan can identify these conditions. Second, correlated is what I have discussed in the previous. That is the ophthalmic examination is one second part. Third part remains the rest of the evaluation. That includes a serology. Especially when you are discussing the serology, IgA levels can remain a positive in mother even after delivery after 3 months. But especially I am more interested in the IgG and IgM. A 4-fold rise in the IgG titer in the neonate or newborn definitely predict that this could be a congenital toxo infection. And of course, the last word is about the PCR is the diagnostic. You can do the PCR with the amniotic fluid, blood, urine, CSF, and that is a confirmatory diagnosis. Of course, the most important is the imaging and ophthalmic examination in cases of the confirmatory diagnosis for the congenital toxoplasma infections.
Okay. And Dr. Rajiv, can we confirm the diagnosis of congenital rubella?
Yeah, surely, ma'am. As in other group of disorders which we are discussing, basically these antibody titers, the IgM antibody titer, if it is detected in less than 6 months in the serum, and as already pointed out, there is a spared sera that if we do the IgG levels, which are present on 2 occasions between 6 and 12 months, that will help us in confirming the diagnosis. And that may be in the, and similarly, we can go for rubella virus detection. There are so many NAT tests, nucleic acid amplification tests are available. but they may not be widely available, I may say. And in a case of suspected congenital rubella syndrome, if it is less than 6 months, so if we can obtain the blood sample, if you can do the IgM testing, which may be negative at times, and then if we repeat within 1 month and if we are having a strong suspicion, then a follow-up test 1 to 2 months, it comes positive, then we may have a confirmed confirmation of the congenital rubella syndrome. Similarly, the IgM may be positive, but there may not be any defect from the group A, which I mentioned, the triad. Then it may be only infection. Even that is taken to be seriously, because that person may be secreting, the child may be secreting the virus for 1 year or so. Similarly, if we have got more signs which were mentioned earlier from the group A and IgM positivity, so that is the confirmation of the diagnosis. Surely we can do the diagnosis, but a single report which we generally get in the OPDs, that may not be appropriate. We may have to have a paired sera samples to check about that whether it's rubella syndrome or not.
Okay.
Thank you.
So Dr. Pratap, are there any confirmatory tests for parvovirus infection, chickenpox, and all? We know that there are tests for HIV, so you can just tell us how to go for it.
Okay, ma'am. Thank you. So for parvovirus B19, high degree of suspicion because of the non-immune high drops, as well as, we can do, if there is any skin lesions, we can do the testing from there, or we can do the blood PCR testing. So that is the, kind of gold standard for parvovirus B19. It is also in the literature causing, severe carditis. So people have actually extracted PCR from, the autopsy sample of the heart of the babies, if the fetus has died. Coming to the HIV, to be precise, DNA PCR is what is needed at 6 weeks of life. And then you should not just leave it there. Then you do a rapid test with a DNA PCR at 6 and 12 months of age of the baby, and rapid test which is done 3 times at around 18 months of age. All these guidelines are from the NACO, and only at 18 months, if things are all the antibodies are negative, then only you are going to say the baby has not got the HIV infection. Coming to your the varicella, basically it's we can always do the varicella PCR, and this can be done most commonly from the skin lesions. Especially if the baby has developed the vesicles. Otherwise, it is going to be specific most of the times. So we go by the history with the mother, as well as based on the skin lesions and PCR. Thank you.
Yeah. So I'll just skip this question because we are short in time. So
Say one word about each diagnosis, just one word.
You want to do it? Okay.
So regarding this congenital Zika, RT-PCR is the diagnostic test. Or if you are going for congenital dengue, we can diagnose antigen by 2 to 5 days of infection, and antibody can be diagnosed after 4 days of infection. But confirmation we will get by 4-fold increase in titer. And if you are looking for influenza, again, the diagnosis is by RT-PCR or rapid molecular assay. Thank you.
Okay. So the summary up to here that we have discussed is that traditional practice of torch titer must be replaced by testing paired sera 2 weeks apart, so that we see, if we see that there is a rise in IgG and IgM, that means there is infection. In all infections, a single value of IgG has got no value. And IgG can be transferred from mother passively and merely reflects a maternal seropositivity. IgM reflecting fetal or neonatal infection have variable sensitivity and specificity. So as we have already discussed, in most of the conditions, nucleic acid amplification tests like PCR, along with a proper history and clinical examination, helps in coming to the confirmatory diagnosis.
32 week करे 34 week आणि थोडा ग्रँड होता माहिती बाकी काही नाही बघूया
We'll try to finish up. So we are showing here the tests which are available for confirmation of most of the conditions. Now to Dr. Sandeep, is isolation needed for neonates with suspected congenital infection?
Madam, when it comes to isolation of babies with suspected congenital infection, as a rule, there is no need to isolate. But there may be few exceptions, like we just learned. We saw the baby with congenital syphilis. These lesions are highly infectious. Or rubella virus, it may be excreting a lot of virus which may be highly infectious from the isolates. Similarly, SARS-CoV, we have realized that this virus can spread in the environment from person to person. So probably these would be the babies where they may be isolated, but when it comes to another infection, it is CMV which is excreted, but it's not a rule that we need to isolate babies with congenital CMV infection. As far as high infectivity, I think SARS-CoV, syphilis and rubella are probable infections where they would be isolated because they may be a mode of spread of infections to other babies or hospital health workers. So these babies may be isolated.
Yeah. So along with that, I think we can also add congenital chickenpox. So there also,
Yes,
when the babies have been
chickenpox.
tested and the mother is also
Yes,
having
madam.
test, there we need to
Yeah.
isolate babies. Yeah. Dr. Kamuzi, if we have seen the benzyl penicillin is not available at present, so what antibiotics should be given for congenital syphilis, and will these babies need follow-up?
Yeah, fortunately, Trypanosoma pallidum remains sensitive to penicillin, and crystalline penicillin remains the drug of choice. Now, we cannot give benzathine penicillin, we cannot give procaine penicillin to newborn babies, so crystalline penicillin remains drug of choice. In case of non-availability, injection ceftriaxone 75 to 100 milligram per kg per day for 10 days is recommended. Follow-up of congenital syphilis babies? Yes, these babies need to be followed up because we need to show the antibody levels are reducing, which is a marker of effective treatment, but also to look for the ongoing symptomatology and ongoing the manifestations, late manifestations of syphilis.
So now I think we would just skip off because the time is short. So we will go to the prevention part now. We'll skip off the other conditions now because.
Sorry, ma'am. Sorry to interrupt, ma'am. We need to wrap up the session quickly.
Yeah, so we will go to the last part. So prevention, can we go for any prevention for these congenital infections? Dr. Sandeep.
Yes, madam. Prevention is always better than cure, and we need to have a screening in terms of pre-pregnancy prevention. So, wherein if the mother has got high risk for rubella, I think we need to vaccinate the adolescent girls and prevent congenital rubella syndrome. Similarly, there are a lot of new vaccines which are in pipeline, which would help reduce the infection rate. Secondly, I think we need to also look at traveling in endemic areas and practicing safe safe sex practices to prevent transmission of HIV and other genital infections. So I think it's very important that we need to look at this aspect wherein it is immunization of the mother, immunization of the adolescent girl and a girl child to reduce the transmission of infections from the mother to the baby. And this is going to give us rich dividends rather than treating babies with congenital infections. We need to also have a screening policy in place wherein mothers with who are high risk, we need to screen and treat if possible in the antenatal period. Avoid going to endemic areas, especially for Zika virus. Insect-borne infection illnesses, we need to look using creams, food precautions, avoid raw meat or avoid eating drinking raw milk, hand hygiene and hygienic practices to prevent mothers getting infection. So these are some of the ways, and obviously it is maternal immunization or maternal vaccination and maternal treatment in the antenatal period if possible to reduce the transmission of the infectious organism from the mother to the baby. When it comes to HIV, people have shown that we could treat the mother and give breast milk in developing countries and avoid breast milk in the developed countries to reduce the transmission of the viruses from the mother to the baby and reduce HIV burden in the pediatric population.
Okay.
So if we have these protocol in place, obviously treating mothers with herpes or chickenpox and syphilis will definitely help reduce perinatal transmission of the infection from the mother to the baby.
Okay.
Thank you.
Ma'am, only thing is that for the rubella, the women who are pregnant should not be vaccinated in their planning.
Mother, yes.
It is
in the
4
antenatal
weeks.
period.
It should be 4 weeks before. That's the only thing for the rubella.
Avoid vaccine in pregnancy. It is before. It's for the adolescent girl.
Yeah.
Even toxo also, it is a preventable disease if it has been treated in time, like a maternal
Yes.
can treat with the spironamycin or avoidance of that mothers with the cat and all the things. These are the preventable.
Correct.
And one more important point I want to highlight about the toxo is long-term management of congenital toxo for 1 year and combination therapy of pyrimethamine, sulfatidine, and in case of chorioretinitis, steroids may be indicated. That is one, and asymptomatic you can give hardly 3 months.
Yeah. So these are 1 year for symptomatic patients, and if the patient is asymptomatic, we go for 3 months. Yeah.
But combination therapy, not a single drug.
Yeah. Yeah. So actually, we would have discussed all this, but because of shortage of time, we had to skip it. But it is available in literature. People can go through it. But what we wanted to highlight is that although rare, intrauterine infections due to various organisms can lead to neonatal morbidity and mortality. So this is important for us to realize. Appropriate history and clinical examination can help in pointing at the organism which is causing the infection. So now most of the time we diagnose intrauterine infection, but we do not try to pinpoint at what infection it is there. So we need to do that so that we can go for a proper treatment where it is available. And nucleic acid amplification tests like PCR are helpful for confirmation of diagnosis. We have already mentioned that regarding the during the discussion. And most infections like syphilis, HIV, cytomegalovirus, herpes, toxoplasmosis have antimicrobial agents which work against a causative organism. This is very, very important for us to realize. Many of these babies can be treated. Prevention, especially in resource-poor setting, which maintenance of proper hygiene, vaccination, etc., which we have already discussed, are very important to be uptaken. Thank you, everyone.
Thank you.
Thank you.
Thank you.
Hello. Am I audible? Yeah. Good afternoon, everybody. It's my pleasure to introduce Dr. Satyam for the topic Recent Advance in Neonatal Resuscitation. Dr. Satyam is Professor and Chair of Pediatrics and Pediatrician in Chief, US Davis Children's Hospital, California. He is having a vast range of experience from active practice of neonatology to research publication in prominent journals around the world. He is the most apt speaker to present on this topic. His research focus on neonatal resuscitation and role of oxygen in regular pulmonary vascular resistance. He has been honored with annual keynote speaker, mentor for Year Award 2016, Best Doctor in America 2007 to 2012, and a Faculty Young Investigator Award. So may I request Dr. Satyan to start his talk on recent advance in neonatology resuscitation. Dr. Satyan, please.
Thank you very much for the kind introduction. Can you hear me okay? Okay, great. So in the next 35 minutes, I will briefly review what is new in the resuscitation of newborn. And before I start, a few disclosures. I've been funded by the Neonatal Resuscitation Program Steering Committee, and I'm one of the members of the NRP Steering Committee that's authors the textbook of neonatal resuscitation. But I want to point out that the views expressed in this particular presentation and some of the figures that I will be showing you are my own figures and do not reflect the official position of the AAP or the Neonatal Resuscitation Program or ILCOR. I also want to reveal that I was a PG student when Dr. Swarnarekha Bhatt gave a NALS course in 1992 in Mysore, and that course heavily influenced me to continue research in this particular area. As many of you know, we have a new edition of neonatal resuscitation now, the 8th edition, and I'll be following some of the new guidelines proposed in this particular textbook. So for those of you who are familiar with neonatal resuscitation, as many of you are, here is a table that goes over the new changes in the 8th edition compared to the 7th edition. To show the same thing in a pictorial fashion, the main changes are that there's a new pre-birth question on umbilical cord management plan. This was not present in the 7th edition. Second, the initial steps of resuscitation are slightly different. We warm, dry, stimulate, position, airway, and suction if needed. The third is that the role of cardiac monitoring has been moved ahead, and instead of waiting till chest compressions are initiated, now it's recommended that cardiac monitoring be started as early as when you start placing an alternate airway, like a laryngeal mask airway or endotracheal intubation. Then there are a couple of changes with dosing of epinephrine and the flush following epinephrine. And finally, if a baby has not responded and has no heart rate at all, previously the plan was to stop resuscitation after 10 minutes, and now it's recommended that it be continued for 20 minutes. So these are the main big changes in the 8th edition of NRP. So let me start off with umbilical cord management, because that's a new question. And as many of you are aware, for most preterm and term infants who do not need resuscitation, it's recommended that around 30 seconds be used for delayed cord clamping. But if you require resuscitation, currently there is no substantial evidence to support delayed cord clamping if resuscitation is needed. And finally, cord milking is not recommended for babies for preterm babies because of various reasons that we mentioned earlier. So the thing that's really concerning when you talk about delayed cord clamping is that there are different guidelines from different sources suggesting various different timings for delayed cord clamping. Here on the vertical axis, you have the duration of deferred or delayed cord clamping starting from 0 seconds to more than 300 seconds, which is more than 5 minutes. And then on the horizontal axis, you have vigorous babies, non-vigorous babies, preterm and term. As you can see here, there are ranges from reputed organizations around the world, ranging from 30 seconds all the way to more than 300 seconds, a 10-fold difference in recommendations as far as delayed cord clamping is concerned. Similarly, interestingly, only WHO and more recently some UK guidelines recommend delayed cord clamping when intervention is required, especially positive pressure ventilation. But most other guidelines currently do not recommend delayed cord clamping when PPV is required for resuscitation. So we need to do a better job and avoid such a high degree of variation while recommending guidelines for delayed cord clamping. So when you talk about cord management, we often think about transfusion of blood only, and that's not the right approach. As many of us know, once we do delayed cord clamping, placental blood is gradually transferred over to the baby, and the baby receives a substantial amount of blood from the placenta. So the benefits of, or the physiological benefits of delayed cord clamping are varied, and these are classified into 3 different categories. The first is hematologic. There is red blood transfer, and the main advantage for this is that there's buildup of more iron stores in the baby. The second advantage is hemodynamic. There is more circulatory stability because you have higher left ventricular preload from getting blood from the umbilical vein. And the third advantage is respiratory. When the baby is still attached to the umbilical cord and the placenta, and the baby's lungs are starting to work due to crying, there are 2 sites of gas exchange in the baby's lungs and also in the baby's placenta. So this is called dual site gas exchange, and that's an advantage of delayed cord clamping as well. Let's look at each of these in greater detail in the following graphs. So in this graph, if you think of the horizontal axis, you have the fetus, delivery, and time in minutes after delivery, 1 all the way up to 10. The red line indicates neonatal blood volume, and the blue line indicates placental blood volume. So the longer you wait, more blood from the placenta is transferred over to the neonate, and you have higher blood volume in the neonate. On the other hand, if you do early cord clamping, then you lose out a significant portion of fetal blood volume inside the placenta. So this is the hematologic advantage of delayed cord clamping. The next is oxygenation. This is a slightly more complex graph. So here on the vertical axis, you have oxygen saturation in percentage. And on the horizontal axis, again, you have time. If you think of the oxygen saturation of the blood coming back in the umbilical vein, it's around 85%. And the longer you let the umbilical venous return continue, more and more blood coming back from the placenta with oxygenated blood at 85% saturation is helping the baby improve oxygen saturation. On the other hand, the pulmonary venous return is not well oxygenated when the baby is not breathing, and in fetal life is around 55%. And gradually, once the baby starts crying, the oxygen saturation in the pulmonary venous return goes up. So in babies who undergo early cord clamping, there's a drop in saturations at birth, which gradually picks up over the first 5 to 10 minutes. On the other hand, when babies undergo delayed cord clamping, this dip in saturation is not that profound. And instead, you have much higher saturations for the first couple of minutes of life, and then pulmonary venous return takes over, and you have similar saturations in both groups. So delayed cord clamping does help with oxygenation in the first few minutes of life. The third, probably the more important of all these 3, is the hemodynamic advantage of delayed cord clamping. So if you think of the left ventricle, which is the main organ pumping blood to the brain, the left ventricle has 2 sources of preload. One is umbilical venous return, shown in pink here, crossing across the oval foramen, coming down to the left ventricle. And the second is pulmonary venous return, coming back from the lung. So when there is delayed cord clamping, there is still blood flowing back from the umbilical vein into the left ventricle. So this left ventricular preload is not deprived, and so this red line continues. At the same token, the pulmonary venous return starts improving as the baby starts crying. For this reason, the combined left ventricular preload tends to be a lot more stable with delayed cord clamping, as shown by the solid pink line, as compared to early cord clamping, as shown by the hyphenated or dashed pink line, which drops down and then starts going back up. This can cause circulatory instability in babies, especially preterm infants, and this can be avoided by delayed cord clamping. So moving along, we have had several sessions on umbilical cord management in this particular conference, so I won't delve into greater detail. But in short, all these 3 benefits, the hemodynamic benefits, the gas exchange benefits, and the blood volume or hematologic benefits are really evident in vaginal deliveries. But with C-sections, which account for approximately 1/3 of deliveries in the US, the benefits of delayed cord clamping are not very clear, especially when delivery is done with an atonic uterus without active contractions, as you experience with spontaneous labor. So moving along, there are different techniques of placental transfusion. One other technique, other than delayed cord clamping, which you can resort to when the baby requires more vigorous resuscitation, is cut cord clamping. Here you cut the cord at a greater length, somewhere around 20 to 30 centimeters, And then you bring the baby over to the warmer and you can start resuscitation. And then you can milk the cut segment of the cord to push in some blood into the baby. And this particular method is called as cut cord milking. The other type of milking is intact cord milking, where the placenta, the cord is still attached to the placenta, and you milk the umbilical cord 3 to 4 times to bring in blood from the placenta into the baby. And this can be done with placental refill, where you allow the umbilical cord to fill with the placental blood, then milk this blood to the baby, and then let the umbilical cord refill with placental blood again. But the problem with milking is that, as you can see in this graph, the red line here shows carotid arterial blood pressure. With each milking, you tend to increase carotid arterial pressure, and these fluctuations in carotid arterial pressure can lead to intraventricular hemorrhage in preterm infants. The interesting thing here is that if the baby is active and actively crying, then you really don't see these fluctuations in carotid pressure. On the other hand, a baby who is not spontaneously breathing or is not being spontaneously ventilated, in those babies, you tend to see a lot more fluctuations in carotid blood pressure, and that can lead to IVH. Why does this happen? If you think of this cartoon, here is a term baby who is actively crying. And when the baby is actively crying, the lungs are aerated, and for that reason, blood tends to flow left to right across the ductus, and there's a lot of blood going into the pulmonary circuit. So in these instances, when you milk, the fluctuations you cause due to milking are buffered by all these extra fluctuations being absorbed by the increase in pulmonary blood flow. And for that reason, the brain does not experience increased fluctuations when the baby is crying and is actively ventilated. On the other hand, if the baby is not crying, as expected in an extremely preterm infant, the lung is still filled with lung liquid and the pulmonary vascular resistance is high. And in these cases, you do not have a pulmonary sink. And for this reason, the fluctuations in the umbilical artery are transmitted to the brain, and these in turn can lead to intraventricular hemorrhage. So preterm babies without spontaneous respiration, especially with vaginal delivery, milking will cause intraventricular hemorrhage and should be avoided. So that's the guideline we have. For infants born less than 28 weeks gestation, cord milking is not currently recommended. Moving to the next section, there are 4 different modes of respiratory support in the DR, or these are the ways in which you can provide oxygen to babies. The first is with masks. Masks are commonly used, and this is the initial intervention we use to provide positive pressure ventilation. But the problem with preterm babies is that sometimes using these masks can be difficult because you cannot get a good seal around the face. The second new modality are binasal prongs, something like a ram cannula or some other methodology where you place a cannula or a CPAP device in the nose, and then you ventilate the baby using that device. This has been shown to be quite effective, especially in a recent CORSAT trial. The third one, which is really underutilized, is a laryngeal mask airway, especially in term infants. This is something that's easily available, but for some reason not very much used, and it's easy to insert. Unfortunately, we don't have really good LMAs for preterm babies, but for term babies, it's a very effective mode of ventilation. And I would strongly recommend that everybody start using this much more often than they currently do, because it's very effective. And the final one, of course, is endotracheal intubation. The trouble with intubation is that you require more equipment, like a laryngoscope, and you require some degree of mastery to intubate the larynx with an endotracheal tube. So a couple of new studies that have come out highlighting the benefits of laryngeal mask airway. Here is a study that was done in lambs by Mani and colleagues, where they showed that even when these lambs require chest compressions, using a LMA was as effective as an endotracheal tube. So just because a baby requires chest compressions, you don't have to take out your LMA. You can do chest compressions with the LMA also. A bigger human study was brought out from Uganda called Pejovic et al., which was published in New England Journal of Medicine last year, where they showed that the use of LMA was as effective as face mask among midwives. So among traditional dyes, midwives, etc., this particular method of using LMA is easily taught, and they can be advised to use this instead of using a face mask. So what I would like to point out is that laryngeal mask is a poorly or inadequately used gadget in the delivery room currently. It can be used instead of a mask or an endotracheal tube. It can be used for initial PPV or during chest compressions. And the use of LMA by traditional midwives is something that needs to be encouraged throughout the world. Let's move on to oxygen. Who doesn't love oxygen? All intensivists, neonatologists, pediatricians, and obstetricians love oxygen, and we use it quite a bit in the delivery room. Here are the recommendations for the use of oxygen in the delivery room. For 35 weeks and higher, we use 21% O2. For 35 weeks and lower, we use something between 21 and 30% O2, and we titrate based on NRP targets for preductal oxygen. And it's not good to use 100% O2 in preterm infants, and these are the current recommendations from the neonatal resuscitation program. But the problem is that 21% O2 works amazingly well for term infants. We have all seen that. But for preterm infants, there are several physiological differences that account for some changes which make 21% not suitable for preterm babies, especially extremely preterm babies. These are really important because in preterm babies, if the baby cannot achieve SATs of around 80% by 5 minutes, if it cannot achieve heart rate of around 100 by 5 minutes, these babies have a very high risk of mortality and also a very high risk of severe intraventricular hemorrhage. These two are important complications that occur if extremely preterm babies cannot achieve a saturation of 80% by 5 minutes of age. In addition, what we have shown in various studies is that preterm babies have really stiff lungs, they don't have surfactant, poor compliance, and they have lower PaO2 values compared to term infants. This in turn leads to poor pulmonary vascular transition in preterm infants. In addition, the lungs are immature, filled with liquid, and the canalicular stage, especially at 24 weeks or 23 weeks gestation, with surfactant deficiency. And for all these reasons, there is poor pulmonary vascular transition and higher incidence of respiratory failure with the use of 21% O2 in extremely preterm infants. So what do the studies show regarding initial FiO2 for preterm infants? There are lots of studies now as listed here, down here. But the basic thing is that if you use 21% for extremely preterm infants, there is one study showing high mortality. If you use 100% O2, there's a study showing increased oxidative stress. And if you use something between 30 and 60% O2, there's really not a big difference among the trials that have been conducted so far. So what do we do here? 21% O2, you can't achieve adequate pulmonary vasodilation in preterm infants, and that's why you see higher mortality. On the other hand, 100% O2, you achieve very high PaO2 levels, and you have higher degrees of oxidative stress in these babies. So one way to circumvent these two issues is the concept of what we call as dissociative oxygenation. What we have been trialing out currently in LAMPS and also in a clinical trial is that in the past, we used to give 100% O2. Before 2000, for those of you who are old enough like me, we used to use 100% O2 for all preterm babies in the delivery room. And that led to very high PaO2 values and oxidative stress. Right now, we practice starting with 30% O2 and slow titration to achieve optimal oxygen saturations preductally. So in the new concept called as dissociative oxygenation, what we have been trying out is to use 100% O2 just for 1 minute when the baby is still attached to the placenta, and then immediately turn the FiO2 down from 100% to 30% and slowly titrate up. And why do we do that? This has two distinct advantages. One, remember the lung requires high amount of oxygen in preterm babies to achieve pulmonary vasodilation. So by giving 100% O2 just for a minute, we've been causing pulmonary vasodilation, but at the same token, not causing systemic hyperoxia because the placenta is still attached and the high PaO2 coming from the pulmonary vein is diluted by the umbilical venous return, which crosses the oval foramen and brings the PaO2 down. So you have a combination of transient alveolar hyperoxia, which promotes pulmonary vascular transition, and systemic normoxia, which prevents oxygen toxicity. And we have been trying this out in babies more recently. As you can see from this graph, by using 100% O2 just for 1 minute, you tend to improve pulmonary blood flow compared to using 30% O2, and you achieve better pulmonary circulation by 1 minute of age, which in turn leads to slightly more stable oxygen saturations. So here is what happens when you use 30% O2 and titrate up. There's a drop in oxygen saturation and then things get better. On the other hand, when you use 100% O2 just for 1 minute with delayed cord clamping, you have much better oxygen saturations. So we've been trying this out for the last few months, and we have a new trial going on called as the DOXY trial, which hopefully I will have some results to present to you within a year or two. Let's move on to the final session in this talk, which is the use of epinephrine. As many of you are aware, in the 7th edition of the neonatal resuscitation textbook, we used 1 in 10,000 epinephrine using with a dose range between 0.1 to 0.3 ml for intravenous dose, 0.5 to 1 ml for endotracheal dose. We gave it as rapidly as possible, followed by 0.5 to 1 cc flush. Several changes have happened in the new textbook, as you can see. Now the concentration still remains the same, but now the flush volume has been increased to 3 ml instead of 0.5 to 1 ml, and the dose has been simplified to suggest 0.02 or 0.2 ml per kg for intravenous or intraosseous dose, and 0.1 mg per kg or 1 ml per kg for the endotracheal dose. You still have the same range as before, but the initial suggested range has been simplified for better memory and a few other advantages. So let's briefly look at endotracheal epinephrine. Endotracheal epinephrine has 2 distinct disadvantages. One is that when you give endotracheal epinephrine in the delivery room, there's a lot of lung liquid sitting inside the lung, and that causes dilution of endotracheal epinephrine and delays absorption. The second disadvantage is that the epinephrine that you give through an endotracheal tube sits in the lung and acts as a reservoir, and when the baby eventually comes back and has a spontaneous heart rate secondary to, say, for example, umbilical venous epinephrine, now there is more and more epinephrine being washed out of the endotracheal tube from the lung, causing high epi values, resulting in hypertension and tachycardia, which can lead to intraventricular hemorrhage in some of these babies. So if you can see this graph here also from LAMS, here is the plasma epinephrine level. You can see that giving umbilical vein epinephrine results in great levels in the blood. On the other hand, giving endotracheal epinephrine tends to cause really lower levels in babies at birth because there is lung liquid. On the other hand, if you give the same dose of endotracheal epinephrine to a lamb who is 2 or 3 days old, when all the lung liquid is already absorbed, you tend to achieve much better levels of epinephrine. So lung liquid does delay absorption of endotracheal epinephrine. And for this reason, you should make every attempt to give umbilical venous epinephrine as soon as possible while giving epinephrine in neonatal resuscitation. Then let's briefly talk about the dose. Why 0.02? Here is a study done in lambs where we have compared 0.01, 0.02, and 0.03 doses of milligrams per kg of epinephrine. As you can see here, the return of spontaneous circulation with the first dose of epinephrine is best with 0.03 dose, but equally good with 0.02 dose, but much lower at 0.01 dose. For this reason, we are recommending the use of 0.02 milligrams per kg of epinephrine through the umbilical vein because it has some of the highest spontaneous resuscitation rates with the first dose of epinephrine. The other advantage of using 0.02 mg per kg or 0.2 ml is convenience. Remember, we always recommend a 1 ml syringe for intravenous epinephrine and a 5 ml syringe for endotracheal epinephrine. So with a 1 ml syringe, if you choose 0.2 ml per kg, if the baby weighs only 500 grams, you can easily measure 0.1 ml dose. On the other hand, if the baby weighs 4.5 or 5 kg, you can easily measure 1 ml dose. So for the whole weight range between 500 grams to 5 kilograms, you can get away using a 1 ml syringe when you use the dose of 0.02 mg per kg or 0.2 ml per kg. On the other hand, if you use a low dose of 0.1 ml per kg, for really tiny babies that are only 500 grams, you don't have a real line on the syringe to accurately measure the amount of epinephrine. Similarly, if you use 0.3 ml per kg, if the baby is more than 3.5 kilos, then you really need 2 syringes, which is a bit of an inconvenience to use epinephrine. So for all these reasons, currently we recommend that when you give endotracheal epinephrine, use a 5 ml syringe, and the preferred dose is 1 ml per kg. When you use intravenous or intraosseous epinephrine, use a 1 ml syringe, and the preferred dose is 0.2 ml per kg or 0.02 milligrams per kg. So moving along, in the previous edition, 0.5 to 1 ml of flush was recommended after injecting epinephrine into the umbilical venous catheter. But what was happening was that in the presence of low umbilical venous line, in the presence of absence of spontaneous cardiac activity, as in cardiac arrest, with chest compressions and high intrathoracic pressure from positive pressure ventilation, it's difficult to propel epinephrine with a 0.5 to 1 ml flush. On the other hand, if you use a higher flush of around 3 ml, it tends to push the epinephrine through the ductus venosus into the heart, resulting in better recovery of these lamps. So here is a graph, X-ray, where you can see injection of just 1 ml of epinephrine, followed by 1 ml of flush. And you can see most of the epinephrine sits inside the liver. On the other hand, when you use a higher volume of flush, you tend to spread epinephrine all over the heart that can result in much better resuscitation of these lamps. So we have also compared 1 ml, 2.5 ml, and 3 ml per kg or 10 ml flush in lamps. And you can see that the spontaneous resuscitation with 1 ml flush is only 43%, with 73% with 2.5 ml flush, and close to 89% with 10 ml flush. But we currently do not recommend 10 ml because there's a concern that pushing 10 ml in a preterm infant can put the baby at risk for intraventricular hemorrhage. And that's the reason why we have gone with 3 ml flush for these particular lamps and babies. So finally, there's a new technique that we have been studying where we administer epinephrine much quickly by an alternate route. So currently what we do to administer epinephrine is that you clean the umbilical cord, you cut the umbilical cord, clean it really well, use the umbilical venous catheter, catheterize the umbilical vein, and then you inject epinephrine, and then you give some flush. All this will take time, anywhere from 3 to 6 minutes based on the expertise of the team. So what we have been practicing is that we have been trying to cut the umbilical cord long, like leave a 20 centimeter segment of the umbilical cord if the baby is not doing well, or if the baby is in arrest when the baby is born. Instead of placing a catheter, we inject epinephrine directly to the base of the umbilical vein. Inject the dose of epinephrine, then take the syringe out, and then you milk the cut segment of the umbilical cord to flush the epinephrine in. Let me show you a brief video of how this is done. So here is a lamb that's in cardiac arrest, no spontaneous breathing. And here is my colleague, Dr. Valley, directly injecting epinephrine to the base of the umbilical cord, the umbilical vein. So he's injecting it, drawing back to make sure it's inside. You can see blood here in the syringe. And then he injects the dose of epinephrine, then takes the syringe out, and he milks the umbilical cord to flush the epinephrine in. This is only being tried out in term gestation lambs right now. And after milking, you can see that the lamb starts gasping in a second. See, there's a gasp. So the lamb comes back with this. So the advantage, at least in lambs, is that the first dose of epinephrine can be given approximately 80 seconds earlier than with the use of umbilical venous catheter. And we can be successful in injecting epinephrine by this route in 70 to 80% of lambs, and probably a higher percentage in babies. So we just finished doing this study in lambs, and we have submitted this paper. And once it's approved, we plan on doing a clinical trial evaluating epinephrine this way. So to conclude, endotracheal epinephrine dose is 1 ml per kg. That's point number 1. Intravenous epinephrine dose is 0.2 ml per kg or 0.02 milligrams per kg, which is point number 2. Point number 3, the flush after UVC epinephrine is 3 ml. Point number 4, we have 4 pre-birth questions now: gestational age, amniotic fluid being clear, additional risk factors, and number 4, the most important one, is umbilical cord management. And number 5, you stop resuscitation if there is no heart rate after 20 minutes. So these are all the new guidelines from the new NRP textbook. Just doing resuscitation is not really important, but providing adequate post-resuscitation care is also very important. And I'm very impressed with the new study that came out from Dr. Suman Rao and colleagues, where they showed that. Can everybody mute their phones if they're not talking, please? And this particular study showed lower mortality with the use of kangaroo mother's care. And this is really important to advocate kangaroo mother's care because this tends to lead to early initiation of breastfeeding. There is maternal warmth provided by the mother.
Oh, hello, participants. Please mute yourself. Please mute yourself. Participants are requested to mute yourself. Can you mute from?
Okay, I'm almost done. So, and then colonization of the maternal microbiome, that's the third advantage. So to conclude, ventilation of the lungs.
Can you mute from here?
Ventilation of the lungs is the key to neonatal resuscitation. Increasing heart rate is the most important sign of effective resuscitation. Avoid cord milking in extremely preterm infants. LMA is an effective mode of respiratory support that should be promoted. 21% O2 may not be adequate for initial resuscitation of extremely preterm infants. And dissociative oxygenation is currently being studied and hopefully we'll have results soon. Avoid giving multiple doses of endotracheal epinephrine because that tends to cause a reservoir in the lungs, can lead to excessive epinephrine doses. UVC epinephrine, the suggested dose is 0.02 mg per kg followed by 3 ml flush. And post-resuscitation care, especially kangaroo mother care, is really important. I thank you for your attention and I'm happy to take any questions. We have a few minutes left. And here is my email address and here is my Twitter account. I'm happy, I follow many of you through Twitter and that's a great mode to exchange ideas. And I really thank you for your attention and for letting me speak at this conference. Thank you so much. I'm happy to entertain any questions either from the audience or from the panel. I'm not able to hear. I think everyone is muted. Even the admin is muted.
Dr. Satyam, can I ask you a question? I'm Dr. Naveen from Toronto.
Hi, Dr. Naveen. How are you? Very nice to see you.
I'm glad. Just that when we audited our recent data on the smallest babies and delayed cord clamping, we figured that most of these babies tend to be hurried to the resuscitation table because the teams feel that they need to get a early PPV or early TP's resuscitation. And these are the babies who will possibly benefit best by delayed cord clamping. So how do we solve this?
Yeah, that's a great question. As you are very well aware, there are a couple of trials being carried out throughout the world. The one that we are eagerly awaiting is a trial called Vent First trial, in which we are participating at UC Davis as well, where you take a sterile CPAP or a TP's resuscitator and the baby is still on the umbilical cord. Intact cord resuscitation is being practiced right now. It is cumbersome. There's not a lot of room near when there's a vaginal delivery, so it's really complicated to provide this, but that's what is being advocated. And hopefully those results that study should be completed within the next year, and we're expecting results to come out by 2023-24. And I think that would be one way of looking at things. The second thing we are practicing right now is the dissociative oxygenation, where the baby is still attached to the umbilical cord and you provide just mask CPAP for a minute to see if that helps. But you are absolutely right. It's a major issue that we are not able to provide delayed cord clamping, and none of the big societies right now are recommending delayed cord clamping when immediate resuscitation is needed. So that's a great question, and we still need more research. Mainly the Vent First trial is what we are eagerly waiting for.
Thank
Dr.
you.
Niranjan, do you have a question?
So this is Dr. Sanjay Niranjan from Lucknow. So may I ask a related question?
Yes,
Can delayed cord clamping reduce the number of transfusions required for very low birth weight and premature babies? Thank you, sir.
Thank you, Dr. Niranjan. That's a great question as well. There have been several meta-analyses looking into this fact, and these analyses do show that in preterm infants, the number of transfusions is reduced by delayed cord clamping. So that's one of the hematologic benefits of delayed cord clamping. You tend to develop higher ferritin levels, you tend to reduce the amount of blood that's required, and both those have been shown. Very recently, the Australian delayed placental transfusion trial, or the APPS trial, was published, and some of the follow-up data have been published, which show that there is reduced mortality from delayed cord clamping as well. And many of these studies, when you pool together, do show reduced need for blood transfusion. So there's definitely a benefit from that regard.
Thank you, sir. Good afternoon. I'm Dr. Vasant Khalatkar. And my question is that in our routine setup, gynecologists are too much in hurry to clamp the cord, So how do you convince them in their setup? Your experience, please.
Sure. Obstetricians are in a hurry.
Yeah, definitely it's the counseling and convincing gynecologists. They feel that we are dependent on them.
No, you're absolutely correct. We face a similar situation in the US as well. And the main reason for adding a fourth question by NRP was to make this a pre-birth question. So what I do now when I go to the delivery room is beforehand, I talk to the obstetrician and say, for example, this baby has diaphragmatic hernia. This baby will benefit from getting fetal blood from the placenta. And I have a slide showing, like, for example, if you buy a new car and you're driving from a long distance, why will you start with the car being half tank full? You want the tank to be full, right? So the blood that's being left in the placenta is baby's own blood. And there is no other way of getting hemoglobin F into a baby. Fetal hemoglobin is so precious. So usually there's a chat between the OB, and once you talk to them and tell them the importance and tell them that you are there to resuscitate the baby, they're usually much more open to doing delayed cord clamping. And I've had much better success with that. So there has to be a discussion saying that you are there to take the risk of what's happening to the baby, and you're requesting for delayed cord clamping. And then you can usually at least get 60 seconds of delayed cord clamping that way. But I do agree with you, we face the same thing in the US as well.
I think it will take time. Foxy should do something. We should request, we are supposed to request for Foxy for all this, right? Thank you, sir.
Yes, ACOG and Foxy have come up with guidelines, and I recently wrote a paper for the obstetrics journal, the OBGYN journal, strongly recommending delayed cord clamping. So we'll see how it goes, but they do realize it now.
Yes, sir. We had one program that is Sat Sat. That is along with Foxy and I.
A request from the organizer that we have to wind up. So,
Sure.
Okay.
Congratulations, Dr. Satyan, congratulations for excellent presentation. Just I have a query from you. Since in India, still the more than 70% of the births are being attended by SPA. And in view of that, we are having our own guideline. And during this rapid evaluation, we are asking only one question, whether baby or not. But in that 8th edition of NRP guideline, there are 3 questions. So how will this, what is your take on this? Will that additional 2 questions have any impact on resuscitation? Dr. Satyan, please.
I missed part of your question because you're not very audible. Can you repeat the part of the question? I know I'm running out of time. So there are 4 pre-birth questions right now. So what was your additional question? Sorry.
Just I wanted to know that during the rapid evaluation soon after the birth, in India, we are having the guideline, and in which we are asking only one question, whether the baby is breathing or crying. But in there are additional 2 more questions. So because of the, for the ease, because still in India, majority of the births are being attended by SBA. So for their convenience, we are asking only one question. So what are the advantages of additional 2 questions? Are there any impact on the resuscitation?
The additional questions are more to understand what risk factors are present on the mother's side. But in the situation that you are talking about, the only thing that really matters is that the baby is ventilating the lungs. So the crying is probably the most important question, because ventilating the lungs is the key to neonatal resuscitation. So I do agree with your guidelines. If you can ask one question, that question should be crying or respiration. And I think that's the right approach.
Thank you.
Thank Thank you so much for the opportunity. Thank you and have a great day.
Thank you very much, Dr. Satyam.
Thank you.
Thank you so much, sir. That was a very interactive session. Now, without any further delay, we'll move to the next panel discussion, that is bleeding neonate and transfusion guidelines, moderated by Dr. Naveen Jain, who will be joining us virtually. And I would request the panelist, Dr. Swapnil, to join on stage. Over to you, Naveen, sir.
Swapnil, are you ready? If you settle down, we can start.
Yeah, I think we are ready.
Good afternoon to the participants of this national conference. I would first introduce my colleague panelists. Dr. Sanjay Niranjan, very senior pediatrician, and as you can see, has held several important positions nationally and in the state of UP. Dr. Kavita, teacher and a very well-trained neonatologist from St. John's and now working at Goa. Dr. Neeraj, trained from All India Institute of Medical Sciences and now Delhi and now working at AIIMS Jodhpur as a teacher in neonatology. Dr. Usha from the home ground of Bangalore, working in Indira Gandhi Institute of Child Health. Dr. Swapnil has done his DM and is now working at Nagpur. And Dr. Satish has done his DNB in neonatology and is working at Visakhapatnam, Andhra Pradesh. Before I go to the first question, I hope I can hear the voices of all my co-panelists. Are you all there?
Yes, sir. Yes. Good afternoon.
Sir, we are here. Okay, thank you. We all know that transfusion is something that comes readily to the mind of clinicians when they're dealing with sick patients and neonates, but is one of the most sore spot for a family. If you say that a baby or a child needs to be transfused or an adult needs to be transfused, it is one of the most important or difficult decisions that the family is going to go. The whole dynasty would get to know that the baby is going to get transfused. So why is there such a dichotomy in the ease with which we clinicians are able to take a part of the body from somebody else and give it to this young baby? And why the families are so uncomfortable about it? So my first question, that why are we having this panel at all, is to Dr. Kavita, that as clinicians, we think there are a lot of benefits for transfusion. We want to help a baby to get better, more oxygen, and sometimes we think more lividity in life. But the whole panel and the guideline is about not having to transfuse. So why should we avoid a transfusion? Is it Really, what are the expected benefits, Dr. Kavita?
Yes, sir. So thank you very much for making me part of this panel. So we transfuse. Why do we transfuse? We transfuse because we think blood transfusion optimizes oxygen delivery to the tissues. But we need to remember that this is a physiological effect, and there is really no strong evidence to say that this effect gets translated into clinical benefits to the baby. But on the other hand, blood transfusion, blood product is a biological product that we give to the baby. So there are multiple risks associated, mainly metabolic risks, which are acute, like hypoglycemia, hypocalcemia due to the preservative citrate, hyperkalemia, especially if we give transfusions more than 20 ml per kg or we irradiate blood. Then there are transfusion reactions, which can be serious, like hemolytic transfusion reactions. We can have, the baby can have febrile non-hemolytic reactions. And the baby can also have transfusion-associated graft versus host disease, which can present later on. It may not present immediately after transfusion. Then there is a major risk of transfusion-transmitted infections, not only in the neonate, but as a whole. There is a risk of bacterial contamination of the blood product, HIV and hepatitis B, which have been identified as major risks from a long time. Hepatitis C can get transmitted to the baby. Syphilis and malaria can also get transmitted via blood transfusions. And then the risk of cytomegalovirus infection in the baby. Blood transfusion is one of the major risk factors for CMV infection. And we need to check the donors for CMV infection before we take blood, but that facility is not available in all the blood banks. And the newly added Zika virus, which can also get transmitted to the blood transfusion. Then we have a category of the non-infectious serious hazards of transfusion. And among these, especially with the neonate, is the transfusion-associated NEC, necrotizing enterocolitis. And as we can see that the odds ratio is almost 2.3 with transfusion versus a baby who does not receive transfusion. And this transfusion-associated NEC is actually the major risk factor for mortality related to blood transfusions in the newborn. The other non-infectious hazards are transfusion-related acute lung injury and transfusion-associated cardiac overload. These numbers are not really reported, but they are risk factors or hazards of transfusion in the neonate. Specifically to neonate, transfusion has been associated with adverse outcomes. So the baby has higher risk of retinopathy of prematurity with an odds ratio of 2.4. It can cause increased intraventricular hemorrhages in preterm babies with an odds ratio of 2.29, and also an increased risk of bronchopulmonary dysplasia with a relative risk of 1.05. And overall, there is an increased risk of abnormal neurodevelopmental outcome with blood transfusions in the newborn. And the last category of patient identification errors, this is obvious because our babies cannot identify themselves. Many of the babies are not named. Their mothers' names may be similar. Two babies may have same names of mothers with the same names. Their date of births may be dates are same. So it is very, these errors can happen more often in newborn babies. Hence, transfusion is associated with major health risks. And the two major trials which came up, the TOP trial and the ECNO trial, have shown that restrictive blood transfusion in preterm babies does not increase the likelihood of death or disability, which means that we should really restrict our blood transfusions in newborn babies. So yes, it is a major risk factors, and we should seriously think before transfusing babies.
Thank you, Dr. Kavita. You seem to have scared the whole hall out of wanting to transfuse because you said everything goes wrong. So I really hope that people find some good reason for transfusing if they must. Dr. Swapnil, we just had a mention from Dr. Kavita that there is a very high risk of infections. Of course, we are transfusing a blood product, something from one body to another. Standards may differ from country to country, but what are our country's national standards which infections must be screened? What is the required standard for blood banks in India?
Thank you for the question, sir. Indian standards, which are defined for screening the blood products, they are mostly screen HIV, hepatitis B, hepatitis C, syphilis, and malaria. So this kind of a testing just to avoid infection being transmitted from blood product to the neonates. However, we need to understand through which process this infections they are getting tested, whether the blood product is having this infection or not having infection. So there is a recent news, a place called Bhandara, which is nearby Nagpur. There is a recent report of having HIV being transmitted to the neonate after a platelet transfusion. So even if the things are getting screened, why these kind of reports are coming that HIV is getting transmitted by blood product? The thing is that what kind of a technology the blood bank is being used, we should join hand with those kind of blood banks who are using standard protocols, which is nothing but a NAT. However, if the blood bank they are using ELISA method, then the sensitivity falls very low. If you are working in remote places, then you should join hand with a blood bank who are screening these kind of infections with standardized protocols.
Yeah, I agree with you, Swapnil. Many times people give excuses that these are adding to the costs of the transfusion product. But we need to remember that once a viral infection like hepatitis C or HIV has been transfused to a baby or transmitted to a baby, it's a lifelong disaster for the baby and the family. So I think every advance that is being made in making transfusions infection-free must be passed on to the patient and especially to neonates. Thank you, Sapna. This will be an important part of the whole session, which may not be strictly a part of the guideline. But for three people, I want Dr. Usha to tell us about the blood product. One is the bank. How are they storing this blood product? It's different for all the products. A practical tip on a resident or a doctor who is standing there and actually transfusing the product. What practical points he should know? And nursing tips. What are the important nursing points that should be known? That what are the things that she should know when she is transfusing or he should be transfusing the product? Dr. Usha, if you are muted, kindly unmute. Kindly unmute Dr. Usha. Thank you.
Hello?
Yeah. Yes, Dr. Usha.
As we all know that the whole blood that is collected in the blood bank, it's usually separated by pheresis into PRBC, platelets, and FFP. So we know that the whole blood that we get, we cannot directly transfuse, and it is separated into three components. And as already being mentioned by the previous speakers, the less we transfuse, the better. So we'll be transfusing only the particular component which is indicated for the newborn. In case of anemia, we'll be giving only PRBC and only, I'm sure the guidelines will be discussed in the later slides. So platelets and FFP, only when it is indicated, will be transfusing, not otherwise. So the PRBCs that we get, it is stored between 2 to 6 degrees Celsius, and it has a longer shelf life of 42 days when the preservative is your SAGM, that is saline, adenine, and mannitol. And it is 35 days if the preservative is CPD. The platelets that we get, it can be stored usually in the room temperature, that is around 20 to 24 degrees Celsius. It can be used up to 5 days after it has been collected. Washed platelets can be used only for a period of 24 hours. And FFP, it is stored at minus 30 degrees Celsius for a period of 1 year. And when it is stored at 4 degrees Celsius, it can be used within a single day. Next slide, please. Now we know that the storage is usually done in the blood bank. So what can be done is when the practical point is when we are transfusing for our neonates, we know that the volume we require is usually less. So volume for a neonate, when it is PRBC, as per the latest NNF guidelines, is that it is 5 ml per kg per hour if the child is, if the unit is not having any signs of CCF, and if there is a cardiac condition, then it is as low as 2 ml per kg per hour. and volume that is required to transfuse, it can be calculated by using this formula. As far as FFP is concerned, it is 15 to 20 ml per kg at the rate of 10 to 20 ml per kg per hour, and platelets can be transfused at the rate of 10 to 20 ml per kg per hour, and the requirement will be 10 to 20 ml per kg only. Indications of platelet transfusion and PRBC transfusions will be discussed in the subsequent slides. And as far as the nursing tips are concerned, as Kavita madam already discussed, that it's very difficult to identify our newborn, especially when they have similar name or IP numbers, which can be confusing. So the first and most important thing is to identify the neonate for whom transfusion has to be done. This, of course, will be under the after a written prescription by the treating neonatologist. So only when there is an absolute indication and there is a neonatologist should a request for blood transfusion be sent. So once it is sent, all you have to do is make sure that the blood which is coming to your NICU for transfusion is cross-matched prior with compatibility tested for ABO and also RH typing. Not just for PRBCs, also for platelet and FFP. Platelet, if it's ideal, even if it's tested for platelets also. So that has to be done. First is identify the patient and see that it is an absolute indication to transfuse. There is no role of prophylactic transfusion of any of the blood products in NICU. As ma'am has already discussed, multiple studies have been done, be it the Cochrane analysis, there are enough guidelines that prophylactic transfusion has shown no benefit, be it in the outcome, mortality, or the neurodevelopment outcome. So we'll restrict the transfusion. And after this, what has to be done is, ideal would be to use a filter when we are using blood transfusion. And blood components must pass through a filter except for platelets. And as I already mentioned, RH negative, female RH negative infants should get an RH negative blood, and transfused blood product should be compatible with both maternal and neonatal sample. So ideal would be to get a sample of mother and the neonate and get the cross match done. And there are a few questions like, I'm sure the nursing staff would ask, should the transfusion, means when the transfusion is going on, should the baby be kept NPO? And questions like this, I'm sure it will be discussed in the slides. Yeah. There is no role or as the incidence of TRANEC, but I'm sure
that question is coming up, Dr. Shah. Thank you.
I think it will be answered. Thank you.
Yes. Very important and very clear messages for the nurses and the practicing resident doctors on how to be done. Dr. Satish, we keep getting to hear about newer blood products and safer blood products and new words like leuko-reduced. Can you tell our audience who may not be familiar completely with what is this leuko-reduced product? What is the benefit? What is this actually?
Yes, sir. Good evening, sir. Good evening, everyone. So of late we could hear the name of leukoreduction or leukodepletion. The meaning is, it's a technical term used for the removal of leukocytes, that is white blood cells, from blood components using specific filters, that is called leukodepleted cells. Each country has its own standard. For example, American Association of Blood Banks, it has own standard. As per this, it has defined that leukocyte reduced RBCs, that is at least 85% of original RBCs should be there, and it should be less than, the WBC count was less than 500,000 in 95% of units tested. Coming to leuko-reduced platelet concentration, at least it should be 5.5 into 10 to the power 10 platelets in 75% of units tested, and it should be less than 8.3 into 10 to the power 5 WBC in 95% of units tested. Coming to the leuko-reduced apheresis platelets, it should be less than 500,000, the WBC count wise, in 95% of units tested. So next slide. So it has different methods of leukodepletion. There is washing, freezing, buffy coat removal, micro aggregate filtration, specific leukodepletion filters, low leukocyte apheresis devices. Among all the methods, specific leukodepletion filters are used, and of late, it's the fourth generation filters are used. It reduces nearly by 99.99% the leukocyte count wise by the mechanism like whenever the blood process to filters, the RBCs will escape through the micropores, whereas the WBC will get stuck there, and moreover it attracts and attaches the other WBCs. That is because the blocking, adhesion, bridging, and interception methods. And next slide. So the types of leukofiltration or leukodetection, it will be two types, that is pre-storage and pre-transfusion. The pre-storage is the best one and done within 24 hours of collection. May use inline filters at the time of collection or post-transfusion. Then the pre-transfusion leukodepletion or bedside leukodepletion, it's a least preferred method. It is used mainly on gravity-based filters, and it may be alternatively performed by transfusing services prior to the infusion. Next slide.
Yeah, thank you. And one more new word that we keep hearing, Dr. Satish, is irradiated blood. So do we really know enough? Can you just tell us what is this irradiation of blood and why we should irradiate?
Yes, sir. So in spite of using the fourth generation filters or whatever may be, still there is a chance of escaping of lymphocytes, that is viable lymphocytes with CD4 and CD8, which would attempt or mount an immunological response against the HLA incompatible host tissue, which normally what happens is the normal host lymphocytes counterattack and neutralize the response. But because of lack of neutralization due to defective cellular immunity or failure to recognize donor HLA molecule as a foreign may lead to transfusion-associated graft versus host disease mediated by transfused lymphocytes. This is the dreaded complication. To prevent, the best modality is the irradiation. So what it causes means it causes DNA cross-link, thereby preventing the lymphocyte replication without significantly damaging the red blood cells, platelets, or granulocyte function. Next slide. So the who are risk and who needs that such products, that is immunosuppressed patients with deficient cellular immunity, congenital T cell deficiency syndromes like Dijorgic, Witzko-Walritz's, and stem cell or bone marrow transplantation, or neonatology wise the intrauterine or exchange transfusion for premature neonates, treatment with purine analogs, and the premature infants weighing less than 1200 grams. These are the risk group we need irradiation, definitely. Next slide. So there are the methods and the dosage. The dosage to the center of the irradiation field must be at least 22,500 centigrams, and minimal delivered dose to any other portion must be 1,500 centigrams. It should not be more than 5,000 grams delivered to the product. It can be done using the cesium-137 or cobalt-60 in self-contained blood irradiators. X-ray irradiator also can be used. The special labels, that is of late no radiochromic film labels which change color upon being irradiated, are affixed to the units to confirm irradiation of an adequate dosage. It hardly takes 5 minutes.
So thank you. At least we have now an insight on two things. One is most of the blood transfusions required in NICU are with the smallest babies, and they are at very high risk of getting transfusion-associated graft versus host disease, CMV infections, and therefore we may have to start asking our blood banks, is it a leukodepleted blood or is it a irradiated blood that we're getting for the small and sick babies? Going back to a very basic thing from this hi-fi of LD and irradiated, Sanjay sir, now it is difficult to ask for whole blood transfusion, which might have been a conventional practice not too very long ago. So why is that we should not be asking for whole blood transfusion, Sanjay sir?
Thank you, Dr. Naveen. The whole blood transfusion has still got a couple of indications, but is restricted because the components and indications are now precise. It is either given for oxygenation or for clotting coagulation factors. So for specific indications, if we give whole blood, the coagulation factors decay very rapidly at the temperature whole blood is stored. And platelets also, they are destroyed rapidly after transfusion. So as different temperatures are required for different components, this is very well said by earlier speaker, Dr. Kavita. So for the best benefit, we need that component to be active and serve the purpose. So when they need clotting and deficiency for coagulation, they need then transfusion plasma. cryoprecipitate, or platelets which are stored at room temperature. Very important point is one donor can benefit several patients, which is particularly more true with the neonates because they need small liquids of 10 ml per kg for a 1 or 2 kg baby. So even one of the 7 components of the blood that can be used multiple times in the neonate. So whole blood, although it is not usually available nowadays, but it is reconstituted bedside by the resident by mixing PRBC and fresh and FFP or plasma, because whole blood basically contains these two things. So whenever whole blood is required, it is reconstituted here and given after reconstitution should be given within 1 hour or so. So when needed, the indications are exchange transfusion and massive bleeding. We use reconstituted blood, and whole blood sometimes is available, but it is also discouraged because the donor who is a directed donor or a relative, it has got more risk of graft versus host disease or alloimmunization. So the practice of previously in my era, you can say, and that only relatives were allowed to donate the blood. Now the relatives are not required to donate the blood. So these are the recent, I think, changes. Thank you very much.
Excuse me, sir. I'm sorry to interrupt, but we have only 15 minutes more before the next talk commences. Thank you.
Thank you for reminding all my panelists, but I think they have been giving very crystal clear images and they have kept your time. Thank you so much, dear.
Thank you,
and taking up one clinical scenario, Kavita, and probably I will just ask all of you to be maybe 10 seconds faster because of the reminder we have got. Is if you have a tiny baby, 29 week or 1 kilo, he's still in the intensive care phase, getting CPAP, getting some desaturations with some bradycardia, and he has reached some number of 10 grams hemoglobin, PCV 31. Should we transfuse? How do you take decisions whether we should transfuse this baby or not?
So this was a little tricky because Sir gave exactly 10%. And obviously, if you see these NNF CPG guidelines, which are based on BCSH guidelines from 2016, this baby falls in this category. That is, he's less than a week old. He's not ventilated. He's on CPAP with an FiO2 of 30%. So his transfusion criteria actually becomes 10 and PCV of 30. So our case scenario has 10 and 31. So as of now, episodes of apnea not requiring FiO2 more than 30%. The answer to the question is no, I would not give a PRBC transfusion. But having said that, because it is just at the on dot of 10 hemoglobin, I would still monitor. If this child has apneic episodes more than 9 in 24 hours, or he requires bag and mask ventilation, or his FiO2 goes up, then yes, he becomes a candidate. But as of now, with this hemoglobin of 10 and his clinical scenario, I would not give a transfusion.
Great. So I think one very clear message Kavita has given is kindly have a working form in your hand, in your unit, which is able to be looked at, and it should not be a subjective decision making. Of course, clinical decisions may be changed based on many other factors, but it should not be grossly violating the protocols or the thresholds that are there.
Just
Yeah, Viniraj, please.
Yeah, just to add that I completely agree with Dr. Kavita. Here, it is very important to keep on monitoring this child very closely. It may happen that the symptoms are because of some disease which are not present upfront at this point. You may need to repeat a screen, sepsis screen after 12 hours or 18 hours, or it may be upcoming PDA, or for that matter, being on CPAP, it may happen that the humidification is not proper and one has missed that cresting part or the dried secretions which is causing these apneas. So it is equally important to look at the other reasons rather than just blindly transfusing these babies. Thank you, sir.
So it's not a solution to all the problems, and let's not transfuse for the want of another answer. Now, if the same baby grows up, reaches 34 days of life, and reaches such a low value of hemoglobin 6.5 and PCV of 20, Swapnil, can you give a brief answer as to whether you will transfuse or not? And if so, what would be the reason for taking a decision?
Yeah, if we go by the guidelines which has been displayed in previous slide as well as this slide, that if the level of hemoglobin is at below that particular level, then we need to transfuse. Now we have to understand for every newborn there will be fall of hemoglobin and there will be rise of hemoglobin, which is a natural physiology of a newborn. But however, if things are going beyond this timeline and we are anticipating that this is not going to happen in which we are thinking, so then this kind of a guidelines will help you to standardize your practice. So as per the question, this baby will require blood transfusions just to avoid more complications related to low hemoglobin.
Thanks, Swapnil. And you can also see that the thresholds had gone down to as low as 6.5 in some units and 7 in some units. So 8, 9 should not be reasons for transfusing stable preterm neonates. Should we withhold feeds during transfusion? This was the other question you were going to answer for us.
Yeah. So the next part of this question is, should we stop feeding while transfusing the neonate? Now, there are various observational studies which have found that there is an increased risk of transfusion associated necrotizing enterocolitis, which is a very risky disease, and mortality associated with this kind of disease is very high. That's why some of the units have formed a protocol that they are going to stop feeds while giving blood transfusions, and which is accepted by the NNF guidelines, which has been published in this year. We are going to stop feeding around 3 to 4 hours before the transfusion, and around 4 to 5 hours post transfusion. Post transfusion, there is no need to start with a small volume of feed and then increasing slowly, so that we can practice this. We can start with a half volume of feed and increase it rapidly. Yeah.
Thanks, Swapnil. Neeraj, this is a recent concern that we have been seeing, and I had asked this question accidentally to both of you, but I still wanted your opinion. Do you actually, in real life, are you withholding feeds in your unit? To be honest.
Thank you, sir, for raising this question. So, as Dr. Swapnil highlighted the evidence, we need to understand two things: that what is the basic pathophysiology of this transfusion-related NEC or associated NEC. So people have multiple reasons, and one says that the initial anemic gut is when you reperfuse by giving this blood, there is a reperfusion sort of injury. But overall evidence is basically in relation to observational studies, and even if you see the recommendations, it is a weak recommendation. So what we practice in our unit is it's a judgment call. Like if the baby is sick, hemodynamically significant PDA, we don't give feeds during that time, but the babies who are relatively healthy and just transfusing them for other reasons, they are not sick, they don't have hemodynamically significant PDAs, we don't withhold feeds in those babies. That's what we practice based on because the evidence still is not robust, and we need more evidence in this direction. But yes, sick babies with hemodynamically significant PDAs, yes, there we withhold for those 3 to 4 hours.
Thank you for that honest image. We will have this answer in brief because we are getting closer to ending time, but we heard a lot about LD RBC and irradiated RBC. Can you answer briefly, Dr. Satish? Is it critical? Should my blood bank have this if I'm looking after NICU? And should this second part will be a little bit more a new point, that should we have to always ask for fresh blood transfusions or RBCs for neonates?
Yes, sir. Here in this, only the 3 proven benefits are relevant in this session. That is, it reduces the frequency and severity of febrile non-hemolytic transfusion reactions. And second is, when you transfuse the blood products along with the WBC, which are infected with CMV, it increases the risk of recipient having the CMV infection. And second thing is, in WBC, it may present as a HLU type 2 antigen, which causes, if it is transfused along with the platelets, the recipient immune system may identify and mount the immunity against immunological response against this one, and may cause the platelet refractoriness. So better to avoid that, we need to have a leukodepleted or leukoreducer products. Other probable clinical relevant are reduced infections risk associated one, and in the it reduces the organ dysfunction, reduces the direct risk of transmissible bacteria. Next slide. Next.
Maybe I'll skip this one and come to the fresh blood point. Do we need to have fresh blood?
That is next slide.
Yeah.
So the effect of fresh blood cells transfusion on clinical outcome in premature and very low birth weight infants, that is RP trial, the age of red blood cells in premature infant study, it in the study, they looked at the primary outcomes like necrotizing enterocolitis, intraventricular hemorrhage, retinopathy of prematurity, BPD, death, and composite outcome of primary outcome of any above. Here in this confidential interval is more than one, so it shows it's not significant. Finally, the conclusion of study was in this slide, the use of fresh RBCs compared with the standard blood bank practice did not improve outcome in premature, very low birth weight infants requiring transfusions.
So even if you have a preterm unit, you don't have to insist the blood bank to ask for fresh blood. You can give for top-up transfusions. You can use stored blood also. Thank you so much, and thank you for allowing me to skip 1 or 2 slides. If there is this is a probably commoner scenario which most of our people in the audience would be seeing, that there is a late preterm baby, got some IV fluids for hypoglycemia, and now he gets infection and he is bleeding clinically from the puncture sites, has a low platelet transfusion of 35,000. So Swapnil, should I transfuse this baby or there is some cutoff value? How do I decide transfusing the sick, larger baby with bleeding tendency?
Yeah, this is a common scenario in RNICUs. However, if there is bleeding, if a baby is bleeding, then you have to transfuse. That means the levels which has been given by NNF guidelines, prophylactically, if you have to wait up to less than 25,000, and if the baby is bleeding if a baby is having coagulopathy along with the thrombocytopenia, then the range is a little bit higher. Now we have to understand why these kind of guidelines are there. If the platelets are low, then we think that the baby might be having increased risk of bleedings. However, it was found in the studies that if we transfuse and we don't follow this kind of guidelines, then there is increased risk of bleeding. Yes, you heard me right. There is increased risk of bleeding. At the same time, at the cost of there is increased incidence of a BPD also. Now, why this is happening? Because neonates, they have platelets which are hypoactive. And once they be transfused with the platelets from adult, which donated by the adult population, then this is going to create a imbalance in the homeostasis of the baby. That's why there is increased bleeding. That's why we follow these guidelines. If platelet counts are less than 25,000, then we transfuse. If there is bleeding and platelet count is less than 50,000, then we transfuse platelet for this. Otherwise, we avoid it.
Thank you so much. We said no prophylactic transfusion. Let us say this baby is not bleeding, Neeraj, but I want to put a PICC line for this baby, which we often do in sick neonates. So should I check platelet counts before I plan a PICC line? What cutoff value should I use to decide whether I can insert a PICC line or not?
So if the baby is bleeding, then of course you need to transfuse as pointed out by Dr. Swapnil also and showed the guidelines. But if the patient is not bleeding, then if the counts are above 25,000, one can safely go with PICC line. But to also consider simultaneously that whether there is coagulopathy or not. Because if the coagulopathy is there associated, then probably the cutoff will change to 50,000, and there you need to first transfuse and then insert your PICC line.
Right. So very importantly, the PICC line has become a common procedure in all teaching program units. Please remember the points which Neeraj said, that you need to check for safety the platelet counts, but a platelet count which is relatively high should not become an indication for transfusion before you do a procedure like a central line. This is another scenario where we consider bleeding as a testing as a practice, Dr. Kavita. I am planning a surgery like a pyloric stenosis baby, suspected has come at 1 month of age, vomiting, electrolytes have been corrected. What all coagulation tests should be done actually before I plan for this baby surgery?
So since surgery is a risk situation for bleeding, we would like to test every child who's going to go into planned elective surgery for coagulation. And the routine testing which we need to do is the activated partial thromboplastin time, that is APTT, the prothrombin time, which will check the extrinsic pathway, and fibrinogen is also important, along with the platelet count. What we need to remember is that the reference ranges, there is no fixed range for every gestation. So for every gestation, the ranges is different. So we need to check the 95th percentile for the gestational age. And then if it is above that, then like there is recommendation to actually correct the coagulopathy before taking up the surgery. So yeah, so these tests we will do before a major surgery is planned.
And suppose this well-looking baby comes with an INR which is high, but there is no bleeding. He is a well-looking boy baby. Then what is running through my mind?
So yes. So first of all, the INR, which is international normalized ratio, is done to avoid the variability between laboratories due to reagent. It is not the ideal measure, especially in neonates, because INR is measured by dividing the measured PT by the control PT. But we do not actually have a control. It's difficult to find a sample with control for neonates. So it is not the correct measure. So we would like to do a prothrombin time and LPDT. But generally, it is considered that INR of 3 is approximately equal to 3 times PT. So if the child is going to go for surgery or the child is having some bleeding manifestation, then we would consider giving FFP. Most common cause in this child, since he is well baby, would be vitamin K deficiency. So we have to take a good history whether vitamin K was administered at birth. At the same time, take a family history for bleeding disorders. If there is a family history, then we would like to do additional tests. And if there is deranged coagulation parameters and the baby is planned for any surgery or invasive procedure, then only we would give it.
Thank you, Sweta. And suppose this baby is the same neonate we go back who had sepsis. Should I give FFP or whole blood as a practice to help this baby in addition to whatever is going on?
Excuse me, sir. We're running out of time.
Yeah, I think we have 3-4 minutes more. Thank you so much.
So platelets are covered. FFP we also covered. If the PT hepatitis is deranged, yes, we would also give FFP. That is a strong recommendation. Whole blood, there is no role, like we've already discussed, but DVT, double volume exchange transfusion, may have some benefits in severe sepsis, as shown by some studies, even though a meta-analysis done by in our group of researchers from our country says that it cannot be refuted or recommended. Most studies are needed, but DVT may be of benefit if there is severe sepsis with.
Thank you for that. Last 2 questions, so the organizers may bear with us because they are important questions. Is Sanjay sir, if we think a transfusion reaction is happening when a baby is being transfused, what are the important steps we should know that we should take on the bedside?
So first of all, stop transfusion and check the labels. As already mentioned, the clerical error is very common. And supportive treatment, which means oxygen infusion and if required PRBC transfusion, infusion for shock and saving kidneys. And hemolytic reaction and anaphylactic reaction are less common in neonates, but tachycardia, shock, hemoglobinuria, these can be the signs. Report to the blood bank with details as per protocol and also the checklist before transfusion that should be followed. And treatment of delayed reactions and infections are treated accordingly, but particularly in neonate infections with platelet, they can be hazardous and they can be emergency also. So they need to be treated as septic shock. Thank you.
And
less transfusions and less reactions. So reduce the number of transfusions. We are getting very liberal on transfusions.
Yeah. I wish we had more time for this question because this is very important, but respecting the organizers' request. The last, but not the least, how can I reduce the transfusion needs, which Sanjay sir said, please reduce. So Neeraj, how can I reduce the need for transfusion?
I think it's a $1 million question, sir. So ultimately it melts down to prevention. The whole neonatology is prevention. But having said that, so I think we have very simple interventions which can be done. And the last talk by Dr. Satyam, we were discussing about the issue of delayed cord clamping. I think that is already a standard of care, and we need to see that how we can further promote this practice in our labor rooms, because it has been clearly shown that it decreases the need of blood transfusions. And if you see in babies less than 34 weeks, almost 1/3 reduction in need of transfusions. And then something which is directly in our hands, the second strategy, that is the so-called routine blood sampling. We keep on doing ABGs on these babies, but without thinking whether it is really going to help. So a lot of samplings in terms of blood gases, electrolytes, and hemograms are done, which are actually not required. So we need to curtail on that, either in form of auditing, and now we have quality improvement tool. And we have few good QI projects from our own country showing that we can reduce this. The third is that how can we decrease whatever the sampling we are doing? So simple point of care testing tools, like we all of we use blood gas machines. So many times we never rely on the electrolytes which are coming. So it is good idea that we club our sampling. We have a machine which gives with 0.5 ml or 0.3 ml of blood, it gives you 4 or 5 analytes. So it is good to invest on those kind of machines. The advantage will be that the blood loss will be less, as well as it is a point of care equipment. So you will be getting the report within 2 or 3 minutes. Then we have iron therapy, though iron doesn't decreases the anemia of prematurity, but it replenishes the iron stores of the body of the babies. So when the erythropoietin starts getting secreted again and the RBC starts getting formed again, at that time this iron is used. If you have not repleted those stores by giving iron therapy in these babies, then they are bound to have more severe anemias and requiring transfusions. So there is some controversial role of erythropoietin, but for all practical purpose, because of the cost issue, the marginal benefit, and now most of us are practicing restrictive blood transfusion therapy. So erythropoietin is not going to play a major role as of now. So I would say that these first 4 or 5 interventions which has been depicted here in the slides are very important to decrease the transfusion needs around our ICUs.
Thank you. Now, the last one-liner from each of the panelists, because when we speak for 40 minutes, nothing is remembered. But if you speak for 40 seconds, it will go home. So one-liner to your listeners.
So I would say that whenever you next time, if we are looking for any blood product, just stop and ask yourself, is it really required or not? I think the job is done.
Okay, great. Sanjay sir.
Back to basics, please check the labels and follow the pre-transfusion and post-transfusion and reaction protocols, treatment protocols.
Kavita ji.
Sir, I have 2 terms. One is restricted transfusion and second, bloodless medicine. So if we can do something clinically and not avoid taking out the blood from the baby, I think that would be the best thing to do.
Usha.
Restrict transfusions as much as possible. The lesser, the better, and better the outcome.
Very good. Dr. Satish.
Irradiation is the best one. If not possible, at least leukodepleted transfusion should be advised.
And back to our anchor, Satish, who is the only person who is in person or real person there. Your message, Swapnil.
Lot can happen post transfusion, which can be life threatening, which can cause major morbidities. So take a decision of a transfusion, maybe PRC or platelet or FFP, depending on the entire scenario of a baby, and try to think where I can go away from giving transfusions rather than going and stabilizing with the blood products.
One question to Neeraj. I think there is a question about some medico-legal aspects about transfusion before we wind up.
So I need to see, sir, what is the question? I haven't seen that.
What are the medico-legal aspects when you're transfusing? Do you need to take consent?
Yeah, so I think that's very important, sir. So whenever we are transfusing, it is important we take the consent, tell the parents upfront the reasons why we want to transfuse and what are the possible side effects. And if you can show your own unit data along with that, that is fantastic. And it has to be a written informed consent. And then as rightly pointed out by Sanjay sir, that all the protocols, the nursing protocol should be there, checking the labeling and all those issues has to be handled. And in case if there is any reaction, then again the same protocol has to be followed. So otherwise it can become a medical legal issue. I can share a very short story. Like when I was doing my DM in PGI Chandigarh, so we had twins, and surprisingly both the twins required the transfusion at the same time. And then what happened that though the bags were checked, but unfortunately the twin 2 blood went to the twin 1. And this got recognized when the twin 1 blood, the staff who was supposed to give to the twin 1, she realized that the number is not matching. Fortunately, nothing happened to the twin who received actually. And the first thing we were able to prevent that, and we talked to the family. But I think these can happen at any time, especially when we are talking of twins receiving at the same time. So it's very important to keep very basics intact while transfusing this. Thank you.
Sorry, sir, but we are running late, sir.
Yeah, we're done. Thank you so much to my panelists to not only give clear messages, to be able to take my polite request to rush through. Thank you for all the delegates who managed to stay on despite many Zoom and otherwise. Thank you so much to the organizers for allowing each one of us to be there, and thanking on behalf of all my panelists.
Thank you so much.
Thank you so much, sir. Thank you, everyone. Thank you.
Well moderated.
Sorry for the interruption. Now we will be moving forward to the next panel discussion.
Leave. How do
On the behalf of Central NNF, the prize distribution, which was planned for tomorrow, has been preponed today because many of the faculty and prize winner have to leave. So this will be given today after this GBM during the time of banquet. So you may convey this to your friends who are getting a prize. Thank you.
Thank you, sir. Come to the last session for the day, which is a lecture. But before that, I'd like to give you a bit of a preamble. We all know that after World War II, Japan was almost ruined and its production line was near deplorable. Although many other Asian countries followed a more agro-based economy, the new generation of Japanese wanted to build a nation that was more industrialized. It was around this time that a Romanian by the name of Dr. Joseph Uran arrived in Japan and gave a series of talks on adding big Q to little q. And what he basically propagated is that it's not just the product quality that matters, but the quality of services rendered. Fast forward several decades, and Japan has now become synonymous with the word quality control and improvement. Not only that, they have shared their work ethic with the rest of the world. Advances have been seen in multiple industries, especially the automobile industry, but relatively less so when it comes to healthcare. Well, we know it's not a car that saves a human, it's an NICU, right? So speaking about this in depth will be our final speaker for the day, who will be joining us virtually. He is none other than Dr. Gautam Suresh. He is the chair of pediatrics and the pediatrician in chief at Nemours Children's Hospital in Orlando, Florida. He's a deputy editor of the Joint Commission Journal on Quality and Patient Safety. He holds a master's in continuous quality improvement in healthcare from Dartmouth and is a member and former chair of the Education in Quality Improvement for Pediatric Practices program by the American Academy of Pediatrics. Unfortunately, sir will not be joining us live, but will be available to take questions at the end of the recorded video. Chairing the session will be Dr. Shishar Agarwal and Dr. Dheeraj Gupta, who will also be joining us virtually. You will now see the video.
Greetings. Thank you for inviting me to speak at the NEOCON 2021 conference. It is my pleasure to present to you this talk on quality improvement in the NICU. I do not have any conflicts of interest to disclose. And I would like to first start by discussing some important concepts and terminology related to quality and patient safety in the NICU. In the United States, the field of quality and patient safety has been galvanized by three important reports that have been issued by the Institute of Medicine, which is now called the National Academies of Medicine. The first, issued in around 1999 or 2000, was called To Err is Human. This was soon followed by a report called Crossing the Quality Chasm. And in 2015, the third report was issued called Improving Diagnosis in Healthcare. I strongly encourage all of you to read these reports because they really provide an in-depth analysis and description of why the quality improvement movement was required in the United States. The report Crossing the Quality Chasm gave us a very useful framework for the domains of healthcare quality, which can be remembered by the acronym STEEP. STEEP stands for safe, timely, effective, efficient, equitable, and patient-centered. And an ideal healthcare encounter should accomplish all these goals. In the STEEP acronym, the last domain, starting with P, was called patient-centered. This concept has evolved further into another new concept that is being talked about quite a bit in the US healthcare system called the co-production of health. So in this model, instead of seeing healthcare as a service that the healthcare professional provides to a patient, health is seen as the result of co-production that occurs during a healthcare interaction between a health professional with medical expertise and a patient or family with expertise of the lived healthcare experience, where they bring their values, their own experiences, their opinions, and they participate in decision-making, execution of healthcare plans, follow-up, and other activities. So they exchange information, brainstorm options, solve concerns, or share decisions as they work together with the health professional. This is a model that I believe we really need to implement and incorporate into quality improvement in neonatology. What are the ultimate aims of a healthcare system? Experts from the Institute of Healthcare Improvement proposed initially a concept called the triple aim, where they said that the healthcare system exists to improve population health, enhance the patient experience of care, and decrease healthcare costs. Bodenheimer and Stinsky subsequently added a fourth aim, so it's now called the quadruple aim, where they said that one of the important functions of a healthcare system is improve the work life of health professionals. And indeed, nowadays, with the alarmingly high prevalence of burnout in health professionals across the world, the fourth aim has become very, very important as a way of promoting wellness and resilience among healthcare professionals. And I think this is an important part of quality initiatives that we should not ignore. Finally, another important concept and term that has become very established in the US healthcare system now is called value. In a simple way, you can think about value as quality divided by cost. And if you want to improve value, you can either improve quality of care, decrease costs, or do both. And the emphasis on value in the last decade or so has been the result of a recognition that healthcare costs in the US are increasing at an unsustainable manner. Right now, healthcare in the US takes up about 18% of the GDP and keeps increasing year after the year, which is not a sustainable pattern. So there is a heavy emphasis on decreasing costs and eliminating waste and improving value. I think this is a very important concept for healthcare in India as well. One way in which we can improve value of healthcare is to eliminate interventions which do not have any beneficial effects on patients or might actually cause harm. And there was a movement called Choosing Wisely across multiple specialties in the healthcare system. In neonatology too, the Choosing Wisely campaign has come up with a list of 5 things that we can safely stop doing in neonatology that will save costs and will not hurt patients or deprive them of good care. They're listed on the slides, and the list includes anti-reflux medications, prolonged use of antibiotics, use of pneumograms, daily chest radiographs, and screening brain MRIs in preterms at discharge. So that was some background material about terminology and concepts, especially emerging new terms and concepts. Let us now discuss why we as health professionals should work to improve quality. In the US, improving quality is not an optional activity right now for health professionals because a range of regulatory and supervisory agencies, such as the ACGME, the Joint Commission, and the Centers for Medicare and Medicaid, mandate that hospitals and health professionals participate in quality improvement projects and explicitly and consciously try to improve outcomes for the patients that they care for. In addition, in the US healthcare system, there are many financial incentives and ranking systems, such as the US News and World Report system, also incentivize hospitals and health professionals to improve the quality of care. The organizations that offer board certification for physicians also mandate that physicians show proof that they have participated in quality improvement projects. This is known as maintenance of certification. However, this has been a very unpopular program and its efficacy has been questioned. To understand why there is so much regulation and scrutiny about the quality of healthcare and so many mandates about how health professionals should work to improve quality, I would encourage all of you to read this fascinating article by Dr. Berwick, where he talks about the 3 eras of medicine. He said the first era was the ascendancy of the profession, where society trusted doctors, trusted them to know their subject and to do the best and constantly try to improve outcome for patients. However, in the 70s and 80s, there was an increasing number of research publications that showed that the quality of healthcare in the US healthcare system was quite poor. There was a lot of waste and inefficiency and a tremendous variation in care across the country, such that if the same patient went to a different hospital, they would get a completely different level of care. This led to recognition by payers, such as insurance companies, regulators, and governmental agencies, that the field of medicine requires more scrutiny. So a lot of accountability initiatives, quality metrics, incentives, and market forces were applied to try and get hospitals and physicians to indulge in activities that will improve the quality of care. This unfortunately led to a lot of micromanagement by all these external agencies. And in response, health professionals and hospitals became defensive, and they started focusing excessively on metrics of quality that were being tracked, and gaming these metrics and ignoring other important aspects of quality that were not being tracked. So Dr. Berwick suggests that in the future, 9 changes are required, which are listed on this slide. And some of them include reducing mandatory quality measurements, stopping complex individual incentives, shifting the business strategy from revenue to quality, and using improvement science in a systematic and rigorous way to improve the quality of healthcare. So while one can certainly participate in quality improvement activities in order to satisfy these external incentives and pressures, I believe that the real reason to participate in quality improvement is that it really enhances your professional satisfaction and gives you meaning and joy in your work. I think if you do not have a good quality improvement program in your unit, you can be stuck in what I call a vicious cycle of quality, where due to a lack of resources, lack of training, and lack of quality improvement programs, there is poor quality of care in your unit. This in turn leads to high morbidity and mortality and high acuity, which leads to excessive workload for the amount of resources and personnel available. This leads to a sense of fatalism, cynicism, burnout, and a culture of low expectations, which further perpetuates poor quality. So there are more preventable complications and deaths not prevented, and further aggravates the poor quality of care. So you can quickly go into a negative spiral with poor quality and burnout and cynicism. If you do have a good quality improvement program in your unit, you will see that there are improved quality outcomes, which leads to lower morbidity and mortality and lower acuity of illness in your unit. This leads to a balanced workload for the resources, a sense of optimism, a sense of satisfaction that your patients have good outcomes, and higher expectations of the type of outcomes that you're willing to accept in your unit. So preventable complications and deaths are avoided, and you go into a virtuous cycle where quality breeds optimism and optimism breeds further quality. And this is the virtuous cycle of quality that I would like all of us to enter in our units. My mentor, Paul Batalden, who was a world famous expert in quality improvement, had a quotation. He said, everyone in healthcare really has two jobs when they come to work every day: to do their work and to improve it. And in a sense, this is why we should participate in quality improvement, because we see it as an essential component of our job to not just do it, but to constantly improve it day after day. And we should be driven by such internal incentives to improve quality and not merely by external incentives that mandate that we participate in certain quality activities. So different clinicians have different levels of engagement in quality in a department or a unit. And currently in my department, as the chair of pediatrics, I'm developing a system where we can measure how engaged a physician is in quality improvement as part of their job. And it's my belief that there can be 5 levels of engagement, the highest level being a physician who actually leads a quality improvement project, and the lowest level being someone who merely follows a quality improvement project guidelines that others develop and complies with them, and all levels in between. Finally, for those of us who are in academics, I want to emphasize that working in quality and patient safety can really help you advance in your academic career because there are a variety of papers that you can write related to quality and safety that are listed in the slide, ranging from a manuscript that merely describes the problem and the quality gaps that exist, up to a paper that really describes elegantly your entire project, where you improved quality around a specific outcome and share the learning from your project with other institutions. So quality and safety is now a well-established academic pathway in many institutions in the US, and I would encourage those of you who have an academic role to strongly think of doing your academic work in the field of quality and safety. Now that we have covered some aspects of terminology and concepts and touched upon why health professionals should participate in quality improvement activities, let's turn our attention now to how exactly one sets up and organizes a quality improvement program in their unit. One of the best frameworks that I have found is known as QAPI, which stands for Quality Assessment and Performance Improvement Program. This is a framework that is provided by the Centers for Medicare and Medicaid Services, and they emphasize that a QAPI program has 5 elements. First, you should clearly describe the design and scope of the program in writing. You should have clear governance and leadership. Who is going to oversee quality and safety in your unit? and how responsibilities will be allocated and time protected. There should be feedback, data systems, and monitoring about what is going on in your unit, and you should be tracking a selected group of quality indicators. That should lead to selection of performance improvement projects, and then there should be systematic analysis and systemic action to improve quality. Many years ago, an expert called Avadis Donabedian described a framework for how to think about quality. He said that quality can be conceptualized in terms of structure, process, and outcomes. To this, we must also add culture or patterns. So here is a framework that I used as the chief of neonatology in my previous role at Texas Children's Hospital, where we focused on structure, process, and outcomes by ensuring that we had enough infrastructure and capacity with personnel, staff, equipment, and physical space. On top of that, we layered specialized programs and projects around the care of specific conditions, such as congenital diaphragmatic hernia, neonates with cardiovascular disease. We had a small baby unit for babies less than 1,000 grams. And then we had focused programs around family-centered care, prevention of healthcare-associated infections, and so on. All these were guided by metrics that were specific to programs and projects, and also generic metrics that we obtained partly from internal data collection and also partly from submission to external agencies like the Vermont Oxford Network or the Children's Healthcare Consortium. So I would strongly encourage you to use a framework such as this, and also the copy structure that I described earlier, to set up a really well-organized and systematic quality improvement and patient safety program within your NICU. Next, I would like to share some specific tips about quality improvement projects and how to ensure that they are successful when you have organized your quality improvement program and you have selected the specific projects to implement within that program. The first tip is to resist the temptation to jump to a solution when you are faced with a problem to fix. Resist getting off-the-shelf solutions that are borrowed from other institutions or from some toolkit or from some publication that you have come across. Really spend some time to understand the source of the problem, why it exists, what are the factors that are holding the problem in place and contributing to it. This is called formulating the mess. And Albert Einstein said it best. He said, if I had an hour to save the world, I would spend 59 minutes defining the problem and 1 minute finding solutions. So spend a lot of time doing process mapping, creating a fishbone diagram, brainstorming with your team, doing some sort of qualitative interviewing, and trying to understand really deeply why the certain specific problem exists and what are the causes and contributors. One of the most important disciplines that will really help you understand a problem deeply and come up with effective solutions is called systems thinking. A system is defined as a set of interdependent elements interacting to achieve a common aim. These elements may be human and non-human. So if you were to visually diagram your NICU or your department, it might look something like this, with different varieties of personnel, equipment, roles, all constantly interacting with each other and influencing how each other works. A very important framework that helps us apply the concepts of systems thinking is that of clinical microsystems. A microsystem is defined as a small group of people who work together on a regular basis to provide care to discrete subpopulations of patients. It has clinical and business aims, linked processes, shared information environment and produces performance outcomes. They evolve over time and are often embedded in larger organizations. So you can think of your NICU as a microsystem that is embedded within a larger organization. So microsystems such as your NICU are embedded in larger entities called mesosystems, such as the Department of Pediatrics. And these mesosystems are further embedded in even larger entities across the organization or a network of organizations or an enterprise, and that can be considered a macro system. So what happens at the macro and meso level will definitely affect how your microsystem functions. And it is important to be aware of the interactions between all these system levels in order to be most effective in achieving high quality outcomes. One of Dr. Batalden's well-known quotes is, every system is perfectly designed to get the results that it gets. So if you want better results, you have to change your system of care. The second tip I have for success in quality improvement is not to use a research mentality, especially with metrics and measures. You should seek usefulness, not perfection, because you're not trying to publish your article in the most high-powered journal. You should use data for monitoring real time, not for evaluation. As far as possible, use disaggregated data that is distributed across time with tribe on the x-axis and the key performance indicator on the y-axis. Use a run chart or a control chart to display the data. The third tip is to focus on sustainability from the beginning, because I have seen and been part of numerous quality improvement projects that start off with a big bang and a lot of excitement, but eventually in a few weeks or months they fizzle out, and all that energy and work that was put in the first few weeks or months is wasted because the project is not sustained. And NICU leaders have 4 jobs. One is putting out fires, and that means there are periodically crises that pop up that will demand your attention. But if that's all you do, you will not ensure a long-term thriving and success of your NICU. You also have to follow organizational imperatives. So when mandatory things come down from the macro system and the meso system, you have to follow those. But internally, you need to be very clear about the strategic priorities for your NICU. What programs do you want to build? What outcomes do you want to improve? What resources do you need? And what does the future look like? You should always be thinking in a strategic way. And finally, you should be building capacity amongst your staff to improve quality and safety constantly over time. There are many reasons why quality improvement projects might not be sustained. One is called organizational attention deficit disorder, where the organization shifts its focus and priorities from one area to the other without really constantly focusing on one goal and achieving success in it and sustaining it. The hero phenomenon is when there is a champion, he or she motivates the whole team and gets success initially. But if that person leaves or gets promoted or moves to a different job, then there is no champion and the whole project collapses and implodes. The low-hanging fruit phenomenon is when quality of care is bad, it's easy to make improvements in the beginning. So you get some initial quick wins, but then it's harder to make improvements after you've reached a certain improved level of performance. So at that time, it's important to continue and persist in your attempt and not give up and be disillusioned. Complacency can occur if you have success in your quality improvement projects. And then because of the complacency, you don't put as much energy or thought and effort into the project. So you get worse results. And then it is common for the teams to exhibit denial that there is a problem and that you have slipped back in your performance. Changing processes without changing culture never leads to sustainable change. So again, like I showed you in the previous diagram, culture was the box that enveloped everything, including structure, process, and outcomes. So paying attention to culture and attitudes is really important. Finally, the washed out phenomenon is when you spend a lot of time educating your team, getting their buy-in, and getting them excited about improving quality. But over time, people leave and they get replaced by new personnel. And those new personnel will not have the history and the track record of the QI project. So it can lead to non-sustainability and a relapse of the previous quality problems. Here's an example of what I'm talking about non-sustainability. This is a graph showing the nosocomial sepsis rate in one NICU since 1994. And you can see that over almost 20 years, the rate of infection bounces up and down, bounces up and down. And every time the infection rate went down, the unit would get complacent and relax, and they would decrease their level of attention and scrutiny. Then the infection rate would spike up, and then they would regather and actively implement measures to reduce infection again. So you want a steady line that goes down over time, and you don't want this kind of up and down chart that shows a lack of constant sustainability. The next step is to come up with quality improvement interventions in a way that works for you when there is no high-level evidence. It's very common when you're trying to improve quality to not have high-quality randomized trials that tell you how exactly to improve an outcome. Therefore, you have to make decisions based on low-quality evidence or even absent evidence. And you should develop a method by which you build consensus on what practices you will implement to reduce intracranial hemorrhage or bronchopulmonary dysplasia or reduce length of stay. And I sometimes call that consistent arbitrariness. So you're making an arbitrary choice, but you're trying to make it consistent so that everybody follows the same guideline throughout the unit. There are two excellent articles which I've listed on the slide, which describe the tension between needing to improve care and knowing how to do it, which talk about the importance of evidence-based medicine and how to make decisions when you do not have high-quality evidence. The framework on this slide is also a very useful framework to think of during quality improvement. It basically describes how measured performance improved is the result of having generalizable scientific evidence, which is adapted to a particular context, and then takes into consideration operational and execution variables. And the team also has to be skilled at understanding system particularities and understanding how structure, process, and patterns interact in that system. The fifth tip is perhaps the most important one of all. I would strongly encourage all of you to use very explicit change management methods and not just simply send out an email or put up a notice or publish a guideline on how you will change practices and what interventions you will apply in your unit to improve quality. So there is a lot of good literature on how to introduce change into a unit. I've listed them on this slide. And you should understand that there are certain things that you do in the unit that are technical things, but success or failure often depends on non-technical aspects of the care you provide, like attitudes, emotions, relationships between different staff members, dynamics, and how certain opinion leaders can influence the opinion of large groups of staff. So explicit change management is very important. A framework that I like to use when introducing change is called SHUCKS. SHUCKS stands for stakeholders. Identify all the stakeholders early during the process and make sure you involve them in decision making. Learn the history of prior change attempts and don't repeat the previous mistakes. Understand the problem before solving it. We talked about it. It's called formulating a mess. Consequences. Think through all the pros and cons and potential unanticipated results that might occur as a result of your change. And how will other parts of the system be affected by this change? Communicate clearly and extensively, and then sustain attention and monitor till the change is hardwired in your system. I'm fond of saying that making change in a unit is like changing Rubik's Cube. You think you're changing just one small part of a system, but in reality, when you turn that part of the cube, the entire cube changes in its configuration. So you have to remember this, and this is an important metaphor for unanticipated or unforeseen consequences of quality improvement interventions as well. The next tip is to learn from failure. This is a picture of the Wright brothers' plane. And if you read their story, they failed several times before getting the plane to take off. And in quality improvement too, you will almost never get a roaring success with your first attempt to improve and change your system. It takes several learning attempts, and you have to be persistent and, most importantly, reflect and learn from your attempts to improve. So in the plan, do, study, act cycle, the study part is the most important, but often the most ignored and overlooked component of the PDSA cycle. So please spend a lot of time on the study part of the plan, do, study, act cycle, and don't jump over it. So the study part of the PDSA cycle is when you compare data to your predictions, you reflect and you summarize the lessons learned. And it is sequential PDSA cycles that build deep learning about your system, which will ensure success and also sustainability. The next tip is to use principles and methods of project management, such as good meeting skills, maintaining of minutes, good documentation of the project as it evolves, formal communication methods and formats which are agreed upon by all stakeholders, and then dissemination methods where you really develop good methods of communicating the news about the project and any changes to your staff and other key stakeholders. Organizing a thoughtful key driver diagram is one good way to organize a quality improvement project. I'm sure most of you are aware of key driver diagrams, so I won't belabor this. But the goal is to really think of your project in logical chunks and organize the plan and activities by those chunks, which are known as key drivers. The next tip is to go beyond the jargon that is commonly used in quality improvement. So it's common for people to quickly learn terms such as silo, low-hanging fruit, maintaining the gains, PDSA cycle. But this just gives you a very shallow and superficial knowledge of what quality improvement is. And we really need to develop a deep level of understanding of how systems work and systems can be changed. So please go beyond the jargon and get a deep understanding. The next tip is to always use a coach for your quality improvement project if possible. And if you're able to get a trained coach who can work with your team and encourage your leadership of your team, your chances of success and sustainability are much improved. So you can get a lot of information about coaching on this website that I've linked in this slide. The final tip I have is to not get hung up on any one format or framework or method for quality improvement. There are many such frameworks that exist today, such as the Lean or Lean Sigma or Toyota Production System, the Intermountain Healthcare course, or the microsystems approach. They all work. Just pick one that is compatible with your unit and your team and use it consistently. The simplest and the most useful model, in my opinion, is the model for improvement, which is widely used by the Institute for Healthcare Improvement, which clearly walks you through three questions. What are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in improvement? And that in turn leads into plan, do, study, act cycles. And as I have emphasized, the study part of a plan, do, study, act cycle is the most important step of a PDSA cycle. So quality improvement is a vast topic and we could spend days talking about it. But in this talk, I try to give you a few essential elements and concepts that are emerging in the field of quality improvement and some tips that will hopefully help you succeed in your quality improvement projects, and most importantly, achieve sustainable results no matter what project you take on. Thank you for your attention, and I'm happy to answer any questions that you might have.
Thank you, sir. We will now take questions from the chairpersons. Chairpersons. Yes, sir, please go on.
Sir, it's good evening here. And it was a very wonderful lecture regarding this quality initiatives, particularly in the neonatology field. And you have covered in here about each and every aspects of the life, which is related to the neonates. Sir, already we have incepted a lot of things regarding the quality control. And we are fortunate enough that in India, we have Dr. Ashok Devari, sir, who is the pioneer and the stakeholder to take these initiatives, particularly in neonatology field, and to start these programs. And he has given us some tips that we had adopted, and we have started thinking about it. It is not only the quantity, it is more of the quality which matters. And regarding that, sir, I would like to ask one question: how quality control in healthcare differs from the quality control in other professions?
Thank you for that question, Dr. Gupta. Can you hear me?
Yes, sir.
Yes.
I am from Varanasi, sir, Kashi.
Okay, nice to meet you.
Prime Minister, sir.
Nice to meet you. Yes, I would say healthcare is behind other professions in its adoption and use of quality assurance and quality improvement methodologies. One challenge has been that healthcare has generally been more of a cottage industry for many, many years. It's only recently that it became more of a systematic enterprise-wide or a corporate type of industry. The other problem is in other industries, especially product-based industries where there is manufacturing, everything can be standardized. A product can be defined and measured, and we can impose standards on how the product should be made and how they should function. So it's easy to have quantitative methods and standardization. In healthcare, every patient that comes to us is different. So it's very hard to approach a standardized manufacturing type approach in the care of patients. So those are two differences between other industries and healthcare.
Then it means that it requires more investment than in other professions.
Yes,
So quality
definitely.
control in
And
healthcare.
there are some things in healthcare that can be treated just like other professions. For example, scheduling patients for appointments, or planning a patient's discharge from the hospital, or the referral process to a subspecialist. All those can be dealt with similar to how airlines book tickets or onboard patients onto the passengers onto the plane and so on. But aspects like diagnosis and assessment of severity of illness, deciding what treatment to use when there is lack of evidence, and how to ensure consistency across different patients when every patient is slightly different is more challenging in healthcare.
That's fine, sir. Thank you, sir.
Hello, sir. May
yes.
I?
Yes, Shishir, go on.
Yeah, I'm Dr. Shishir Agrawal, sir, and I think I've spoken to you once. It was a wonderful, wonderful lecture, the key points which you have given, and one sentence you said that we have to go to work every day and we have to improve our work every day. That was something really catchy. I just wanted to know, I've also been to US, I've worked somewhere for some time there, now working in India. And but in US, everything, each and every patient has got insurance, and everything is covered, is covered in health insurance. So the most important thing is that whatever kind of treatment is required for a very sick neonate or infant, insure, and money is not a problem. And in India, the health system is really different. In India, health insurance system, I don't think there is any health insurance system for neonate babies. And to give quality care to those neonates, sick neonates with the limited resources, if at all we want to improve the quality and improve the resources, we need the funds. And one more sentence you added, that we need to not to focus on the revenue, we need to focus on the quality. This right sentence, we need to focus on the quality, not on the revenue. But ultimately, to provide quality, we need funds. And all these machineries which are used in critical care in NICU and these instruments, these are pretty expensive. The resident doctors and the technicians, all these things. I hope you're understanding what I'm trying to say. So, and the American model is definitely different. I've seen that. But how do you suggest about working in an Indian model to give high quality care with the minimum amount of expenses? Thank you.
Thank you for that question. I did my MD, DCH, and DM in India from PGI Chandigarh. So I'm familiar with the Indian context, and I visited many hospitals periodically. So I have some understanding of the Indian healthcare system. So I think quality improvement is even more in the Indian healthcare system, where many patients pay out of pocket. So it's very important to ensure that there are no errors and lapses in quality when we're taking care of patients in India. The question we should ask in a resource-constrained setting, in a setting like India, is, are we delivering the maximum possible quality of care possible for the amount of resources and personnel that we have? So that is the question. Instead of aiming for an ideal target, we should say, are we achieving the maximal possible goals given our constraints and resources? So that is one response that I have. The second response is patients in India are now more aware, they're more well-informed, and they expect higher standards, and they will not simply accept what the doctor says. So there is a strong business case for quality as well, because if you provide good quality care and the patient's outcomes improve, your reputation will increase, your patient families will be more satisfied, and that will bring in more referrals to your hospital, and you go into a virtuous cycle. The final thing I want to emphasize is those 2 slides where I talked about the vicious cycle and the virtuous cycle of quality. And if you really do good quality of care and patients' outcomes improve, not only are the patients satisfied, but the staff are satisfied. Plus, you can be more efficient in taking care of patients and discharging them so that you can fill your beds with new patients and increase revenue. So there is a strong business case for quality. And if you improve quality and deliver good outcomes, it can increase your revenue and further provide resources for improving quality. So that's my response to your answer. Thank you.
Sir, I completely agree with your answer. As far as it is concerned with the bigger cities like Delhi, Calcutta, Bombay, Bangalore, Lucknow, all these places. But when we go and visit the smaller district level places and village level places at the peripheral centers, at the PSC centers, where the paying capacity is really, really low, they cannot afford even 5,000, 10,000 rupees for the entire treatment. And the baby is really sick and baby requires ventilator support, baby may require other supports, transfusion, there are a lot of things which are required. In such cases, at the peripheral level, what we should be doing to improve the quality of care?
Again, I think a lot of things can be done within existing resources. For example, if you look at SNCUs, they have a lot of resources and they have good funding from UNICEF and from the government. But the potential for performance is not being maximized in SNCUs. So a lot of tertiary centers are now serving as mentors and coaches to SNCUs. And that is one way in which we can raise the performance of SNCUs. Because the people even in the peripheries, they're very receptive to education and guidance on how to maximize their performance. And I know lots of projects where teams have gone from the US to teach people quality improvement and teach them how to improve their performance, and they have been very receptive. Is it ideal? No, it's not ideal. But I think there is a lot we can do within our existing constraints and resources. Thank you. And I think in India, the NQOCN is doing a lot of great work to spread the methods and knowledge about quality improvement and address exactly the kind of things that you're talking about in government hospitals, PHCs, SNCUs, and peripheral hospitals. Sorry, there was somebody else who was asking a question.
Dr. Junia, is there any questions or I will ask?
No, you can continue, sir.
Okay. Sir, one of the problems in our country is that we now are adopting a lot of things and we can start anything, however expensive it may be. But when the project is started, but sustainability is not there. That is the main problem with any project. The same is coming with this QI control also. Sir, in one of your slide already, you have dealt with that we have started or taken the initiative to start the things, but it not keep on the same pace with which we have started the thing.
Yes, this is a persistent problem, and this has been a problem with all public health programs, and it is a problem with quality improvement programs as well. So the key is to select the projects very carefully and use your resources wisely on the high priority projects. And the other key is also to maintain constant attention and vigilance where you meet regularly, review the data, and make sure that you don't take your attention off the topic. So these 2 things I believe will increase the sustainability of quality improvement projects. And sometimes you have to realize that what you're doing is not working, and you may have to abandon a project and say, we need to change and devote our resources to a more important project where we have a higher likelihood of success. So I think there has to be careful thought about selection of projects, maintaining attention, and occasionally abandoning projects. Thank you.
Would anybody else like to put forth a question? Dr. Dheeraj, kindly unmute yourself.
Okay. Sir, in one of your slides, you have mentioned the hero phenomena. What it is, sir?
Hero phenomenon is when there is a great champion for a specific intervention or a project where they're very passionate, they really believe strongly, for example, in CPAP or the use of mother's own milk or in hand hygiene. So that person energizes the entire staff, gets them to buy into the project, excites them, and can bring about change. So that person owns the project and is the hero for that project. But because they're so good, they often get promoted or they're given additional responsibilities, or they may get hired by some other hospital or NICU. And then suddenly the champion is gone and the project can collapse because there is nobody else to be the champion for that project. So that is the hero phenomenon. So ideally, the ownership and the responsibility for projects should be distributed across multiple people. So even if one key person leaves, there are other persons to continue the work. You do want champions and you do want people who can excite and energize the staff, but you don't want the entire project to depend on one person.
That's it. Thanks.
Thank you, sir. Any more questions for Dr. Suresh? Okay, I understand it's very early in the morning for Dr. Gautam, and we have been keeping him awake all night. Thank you so much, sir, for that thought-provoking speech. I'm sure it's inspired everybody here, both physically and virtually. Thank you very much, sir. And
Thank you so
especially
much for inviting me, and great to see everybody. Take care.
Thank you so much, sir. Have a good day.
Thank you, sir, for all your
Bye-bye.
blessings and a
Stay in
good,
touch.
good talk.
Stay in touch. Take care. Bye.
Thanks. Bye.
Thank you, sir. Thank you. With that, we will be concluding today's session of day 3 of NEOCON 2021. I kindly urge all the delegates to move to Hall A, where the annual general body meeting will be held. Thank you and have a safe trip back home.
Bye, Dheeraj bhai.
Oh,
Sir, good to see you, Dheeraj sir.
Same here, Shri Sashir. Same here.
सर तिरुपति जा रहा हूँ, रास्ते में हूँ.
Very good.
सुबह टॉक था वो खत्म कर लिया, कल और परसों था टॉक वो खत्म कर लिया, तो मैंने कहा चलते तिरुपति. कल भी 2 टॉक है लेकिन दोनों वर्चुअल करूंगा.
अच्छा, नहीं ठीक है, वहां गए हो तो अब यहाँ पे ठंड बढ़ गई है. It is slightly colder here. Very cold today.
हाँ, ठंड बढ़ गई सर. अरे धीरज सर वो टीओटी वाला देख लीजिए सर.
भेज दिया हूँ शिशिर. मेरे हाथ
follow
से
up
जो
करे.
था मैंने उसको फॉरवर्ड कर दिया हो.
अच्छा सर, अच्छा सर.
मैंने ऑलरेडी फॉरवर्ड कर दिया.
ठीक सर, थैंक यू सो मच सर, थैंक यू सो मच. अच्छा हुआ सर वर्चुअल हम लोग जूम पे मिल लिया करें सर, अक्सर अच्छा लगेगा. आपका देख के मुस्कुराहट देख के मजा आ जाता है सर.
चलो एंजॉय करो.
साउथ इंडिया में लोग मिले थे.
एक सेल्फी ले लो, एक सेल्फी.
भगवान को प्रणाम बोल देना.
स्क्रीनशॉट.
स्क्रीनशॉट ले लिया सर.
कोई जना स्क्रीनशॉट ले लो.
मैं एक मिनट, आप स्क्रीन पे आइए, मैं लेता हूँ स्क्रीनशॉट.
हाँ, मैं
ले लिया स्क्रीनशॉट. मैंने ले लिया सर.
थैंक यू.
भेजता हूँ आप लोग. ले लिया सर, तीनों की आ गई.
अच्छा अच्छा,
ठीक है, स्टॉप. हाँ, मैं भी रिकॉर्डिंग हो रही हो.
ठीक सर, ये रिकॉर्डिंग बंद हो गई.
ओके
ओके सर, हैव एंजॉय योर इवनिंग. मिलते हैं सर.
बाय. मिलते हैं.
चलो बेस्ट ऑफ जर्नी यार शिशिर.
थैंक यू सर. बाय.
Good evening, dear friends. Please take your seats. Please be seated. Friends, please come inside and please be seated. We'll be soon starting the award ceremony. Dr. Manoj. Dr. Srinath Maniganti, sir, please have your seat. Ravi, please sit. Friends, for your kind information, we are having a certain award category which we are introducing for the first time in NNF. We had certain competition in which we had overwhelming response from the states and institutes. And we'll be felicitating all those institutes and awards and the students who worked hard for various NNS programs this year. So to start this ceremony, may I request our new President, Dr. Siddharth Ramji, sir, to please come on the stage. Dr. Ramji, sir. May I request Dr. Ranjan Kumar Pejawar to please come on the stage. May I request our dynamic Vice President, Dr. Dr. Lalan Bharti to come on the stage. And may I request our ever charming Finance Secretary, Dr. Surendra Bish, to please come on the stage. Neetu, are you ready? Neetu. So first of all, so before we start the award ceremony, I'll request Dr. Ranjan Kumar Pejawar, who all planned and instituted all these awards and ceremony, these prizes this year, to please come and say a few words. Then we'll start the award ceremony.
Hello. Good evening, friends. Since we are all friends, I'm not going to read a big list of welcome. The office bearers of NNF is here. Rightly so, because we had introduced certain advocacy days, which we encouraged the states to do activities, and many of the states responded very well. We were so thrilled that we involved them and they responded. And just as a fun activity, we had competitions, and they abided by the rules, and they sent in entries, and they were independent judges, and we have a list of awards to be given. The advocacy days, you will know what are the ones we have started. But before starting that, you have already heard in the general body meeting, the organizers of this event, how much of work they have done, how much of tension they have gone through, and how much of uncertainties they have faced, and how much of change from virtual to physical, physical to virtual, even till the last minute. There were some people who were virtual and some people who were physical, and suddenly exchange of these things happened. Speakers could not be contacted. So there was a lot of hassle. Please remember this. This will be a unique conference. It is the first hybrid conference of NNF, and the experience was, I would say, quite challenging. That's the mild word to use. But they have faced all these difficulties and successfully held this. This is the last, like they call in the Bible, the last supper of the conference. And we are going to have this ceremony, after that chill out and enjoy following the COVID restrictions. Very, very important. Okay, so now I hand the mic back to our dynamic secretary, Dinesh Tomar.
So we are coming to a happy ending of this conference. So first of all, we like to start this award ceremony by felicitating our organizing team who worked in spite of all the odds throughout the year. They were not sure how to conduct this conference till the very end. To start the felicitation, may I invite Dr. Srinath Manikanti on the stage. Yeah, this is the initial awards are for the organizers. May I request Dr. Ramji to please felicitate the organizing team. May I invite Mr. Ganesh, who has been a constant support to this organizing team, to please come on the stage. Mr. Ganesh. He's not here. Anybody else who can come and collect on his behalf? You come and collect, okay. No, not like this. Dr. Arvind Shinoy, sir, for crafting a very good scientific program. Arvind Shinoy, sir. Dr. Kishore Kumar, sir. Somebody else to come, please, and collect. No. Dr. Dinakar Prithviraj. Dr. Kuturesh, sir. Organizing team, sir. Dr. Bidri, sir. Dr. Bidri, sir, please. Dr. Prashant Goda. Dr. Prashant. Dr. Jagdish Somana. Dr. Jagdish. Jagdish, he has come.
Say yes to
Jagdish, he has
easy
come.
year-end savings. Get flat 25% off on medicines, cashback up to rupees 1 lakh daily,
And
assured rewards on every purchase. Hurry, order now.
Mr. Darshan, who has worked tirelessly for last 3-4 days. Now I request Dr. Ranjan Pejawar to please present the next set of awards. We had a very challenging award to be given, which was a very tough fight for this award. It was Newborn Week Celebration 2021, and the best of the branch which did this was West Bengal branch. So I request the NNF West Bengal branch to please come and have this award. Newborn Week Celebration 2021. NNF Telangana branch as the first runner-ups. Members from NNF Telangana branch. So please. So Jagdish, you please come and collect. NNF Orissa as the first runner-ups. Second runner-ups for this award. Then there were tough fights, so we had one more branch which was very close. So we gave President's Special Appreciation Award for Newborn Week celebration to NNF Punjab branch. Members from NNF Punjab branch, please come forward. Then we have the Best Breastfeeding Day Celebration Award. Even for this award, there was reports from the branches running into 100 pages. And the branch which has won the first prize in this category is NNF Kerala branch. First runner-ups, okay, let them. No, after this, First runner-ups closely following them with a tough fight was NNF Rajasthan branch. Members from NNF Rajasthan. Yeah. Yeah. NNF Orissa branch as the second runner-up. Another branch which had a very good presentation, but their report reached 1 day late to the office. But their presentation was so good that we had to give a special award to that branch. And none other than West Bengal branch. They did very fabulous celebration of this breastfeeding day celebration. They started a new website, they created videos. Can I request our dynamic Vice President Dr. Lalan Bharti to present this award? Then we had the best videos for breastfeeding. And in this category also, the first prize goes to NNF West Bengal branch. So you stay back and collect one more award. Best video on breastfeeding. From Uttar Pradesh. Yes, sir, please come. Then there were few institutes who did excellent celebration, and you chosen 3 best institutes. For celebration of breastfeeding week. The first award goes to Mukunda Christian Leprosy and General Hospital, Karimganj, Assam. Anybody from Assam here? The first runner prize goes to Ankura Hospital, Bodupal. Is it near your place, sir? Jagdish Chandra. Ankura Hospital, Bodupal. You collect. I'll ask you to collect from your place. It is near Andhra, no? Yeah. Yeah. And the voluntary health services, Taramani, Tamil Nadu. Dr. Rema, you can come and collect on their behalf. You are coming? Yeah. Okay. Nice. Then we come to another important celebration which started this year itself, for Nurses Day celebration. The first award goes to NNF Tamil Nadu branch. एक वेस्ट बंगाल का जो बाद में I now request our Finance Secretary, Dr. Bish, to present the rest of the awards. The first runner-up in Nurses Day celebration category is NNF West Bengal branch again. The second runner-ups are NNF Goa branch. Somebody from Goa or somebody from Maharashtra who can collect on their behalf. Amit, you can come. Then the best institutes who celebrated Nursing Day in a grand way. The first prize goes to Akansha Hospital and Research Institute, Anand, Gujarat. Or Somchekar. The second award goes to Dr. Archana Bilagi, St. Philomen's Hospital, Bangalore, Karnataka. Anybody from Karnataka and can come and collect this award on behalf? Yeah.